behavioral health. And I'm thrilled that this is our first collaborative meeting with the New York City Coalition for Behavioral Health, the Children's Committee. And so it's really a very exciting time. So what we'll do is we'll go around, we'll introduce ourselves, and then I'll ask the two co-chairs of that committee to say a couple of words if they please, and then we'll go to our guests. So with that,
I'm Joanne Caswell. I'm the Executive Director of Families First in Essex County, and I'm considering possibly joining this board.
well,
Hi, Elizabeth Nolan, Hillside Children's Center, and a member of the Coalition Board. Coalition for Children's Behavioral Health.
Lisa Kinney, Hillside Children's Center, and I'm a family member on the New York State Coalition.
I'm Vivian Santana, I'm a family member, and also I work for the Goldsmith Residential. Hi, I'm Trish Lichnick. I work with After Services, and I'm also a parent rep Coalition Board.
Hi, I'm Bridget McBrien. I work in government relations here at the Jewish Board.
Elizabeth Osborne, I work for the Jewish Board. I'm the director of the Iddleton RTF, Iddleton Day Treatment, and Green Cross CRs. I'm Fern Jager. I'm the CEO of the Staten Island Mental Health Society. I am the co-chair of the Coalition Children's Committee, and I'm on both boards.
Jerry McCaffrey, I'm the CEO of Mercy First, a member of the Coalition.
Jim Irene, SCO, Family of Services, and I'm on the board of the Children's Behavioral Health Coalition.
Steve Balger from Kids Oneida, and I'm also on the board of the Children's Coalition.
Hi, Robert Sidmer, South Central New York. I'm the co-chair with Fern of the Coalition, and also part of the other coalition.
Double winner. Whatever, whoever takes us.
Good morning. I'm David Goldstein. I'm the Vice President of Child Health and Wellbeing at JCCA and on the board of the Children's Coalition.
Good morning. My name is Annie Kramer. I'm with the OMH Psyche team, here to chat with you today. I'm not on the board, unfortunately.
Hi, I'm Patricia Gallo-Goldstein, formerly of the Coalition, but now also with Psyche OMH, and here to do the presentation today.
And I'm Andrea Smith. I'm the Executive Director of the Coalition, and I understand that we had 45 people registered to attend via webinar, so we welcome you. And I wanted to give Fern and Rob a chance to welcome your members, you know, if you have anything to say to the committee specifically.
Just first, Nicole, if you could give the instructions you'd like to give to those on the phone.
Hi everyone, just wanted to let you know that today's PowerPoints are available to be downloaded in the Handouts tab, and if you do have any questions throughout the webinar, you're welcome to type them in the questions box and I can ask them aloud for you, or once we get into the full meeting, if they ask for me to unmute you, I will unmute you. Just make sure you dial in your PIN when asked. Thank you.
And Nicole, this is Andrea. Are we going to record the meeting so people can? Yes, thank you. Fern or Robert, do you want to welcome your members?
Welcome to everybody. We're very excited about having this joint collaboration. We think that there's a lot of energy and power and ability to understand and make changes when we join our resources and our understanding all together. From the point of view of the Coalition for Behavioral Health, this is really a reforming of the committee that we've had. We used to have a very active children's committee in years past, and there was a number of changes. That committee wasn't as organized and, in my view, as effective as it had been in the past. But it's been reorganized, and having Andrea coming and helping lead us through has been a real shot of energy and information. So we've already reaped the benefits in a fairly short time of coming together and see potential moving forward. Good.
Just want to echo what Fern just
Speak up.
I just want to echo what Fern just stated, and the synergy of the first few meetings with Andrea being representing and working with the coalition has brought a new fusion of energy, but also brought in both upstate and downstate, which in this changing environment, we need to really coordinate all of our advocacy issues, because one state and all these issues should not have like two separate ways of doing things. So as we're coordinating, we're getting better results, and both from advocacy, political, and the other issues that come out. So I'm very excited about this. So welcome, everyone.
So that's great. So we are thrilled to have a longtime friend of all of us, Pat Goldstein, and her colleague Annie Kramer, to talk about psyches.
And this is Andrea. We often invite guest speakers and begin our meetings that we do in person or sometimes via webinar with a presentation of something of import to the operation of the field. Sometimes it's clinical, sometimes it's policy, but we thought that there was enough new news about psyches that it warranted having Pat and Annie with us today. So welcome.
So thank you very much. It feels so good to be here and see old friends as well. Thank you, Jim. Thank you, Andrea. So I wanted to reach out to Andrea and the children's group in particular, because we know that the field for children in particular is shifting dramatically. And we wanted to be here to start a conversation after the presentation itself about how can we help you? What could psyches do? What are the kinds of things you would like to see in psyches that potentially could help you as you move forward into a host of new services? Hopefully, right? We all have our fingers crossed. So I am here with Annie Kramer, who is also very well known in the field, particularly the JBSCS, because she was the director of evaluation and review here at JBS for many years. And at Psyches, we feel very fortunate that we were able to have her come and join us. So what Annie's going to do is she's going to run through, because I know this is a very diverse group, and she's going to tell you a little bit about psyches. She's going to tell you about some of those real enhancements. She's going to talk a little bit about some of the really great innovations. And then we're really going to open this up so we can have a little bit of a conversation to answer your questions and start that conversation about, okay, if you're moving into new services, what might you like to see in psyches? I remember from the coalition that the children's groups always said, we're not heard, we're always heard last. So let's put you first this time, okay? Annie, I'm going to shift.
Okay, trade thoughts. Thank you, Pat. Good morning, everyone. So as Pat mentioned, historically the psyches projects have been primarily for outpatient clinics, for example, or hospitals. We've really done one main child-focused project, which was a hospital-based readmissions project from 2014 to 2016. It was really looking at reducing readmissions in children's hospitals. So what we want to kind of show you today, for many of you, this might be the first time you've seen psyches, and for those of you who've used it, you'll have to bear with me as I go through some old favorites or less than favorites. And then we want to see how can we be helpful. So here's just the background. So psyches is an OMH web application. We share primarily Medicaid claims information. We also have some other state administrative data, and I'll be showing you what that is shortly. It's secure, it's HIPAA compliant. We go through the same security processes that other OMH systems do, and there's a variety of things that you can do in psyches. And so we wanted to show you all the different ways you can slice and dice that data today to get both an aggregate view of your population and learn what's going on overall, and also individual client level data. So who's in psyches? Primarily Medicaid enrollees. And what we're moving towards is entry of non-Medicaid enrollees, but at this stage it's primarily Medicaid, both fee-for-service and managed care. For the duals, we only have certain Medicaid bills in the system, and we can look back, at least for Medicaid, about 5 years. So it's primarily behavioral health, and as it shows, 6 million folks are in the system. And one of the interesting things is if you have somebody historically who was not Medicaid, you weren't able to get any data, you weren't able to put in any data. And as I mentioned, we're moving into a place where people are going to be doing data entry of non-Medicaid individuals, so there's going to start being information about them in the system. So we get everything that's on claims, basically. Medications, pharmacy, we get hospital stays, you get the individual doctor's level, you can see the date discharged, the date admitted, all of that good stuff. But of course, because we're getting it from claims, there's going to be some time lags. So we used to have a time lag of a couple months by the time you bill. Sometimes you get declined and you have to rebill, and that goes to DOH. It would take a few months for us to get the data. Now with managed care, it's anywhere between 3 and 6 months because there's another player that the data is moving through. However, we do have some data in the system that is more up to date. And this is data that we're pulling from other state databases. So for example, you can go in and find pretty accurate up-to-date information as to if one of your clients has, is in a health home, for example, and we're starting to get that kind of information, or part of an ACT group or AOT. Now, that might not apply to a lot of children's programs, but the more that we can get from a CARES or a NYMERS, for example, the more that we can put in the system and have that integrated data. And we'd be interested to hear what you'd like to see in an integrated way in the system. One of the things that we're working on right now in particular is we're working on some interoperability with the department, with DHS, to start to get shelter data into the system. Right now, we're just going to give them a view so they're able to see who has a health home care manager, who has an ACT team when a client comes into the shelter. But the next phase is we're going to be getting DHS shelter data into psyches as well. So I'm going to go through the application in brief. These are some of the highlights. This is the landing page, and for those of you who know psyches, apparently you cannot see it at all on this slide. It is incredibly blurry. It's lovely on my screen. If only you could all be sitting behind this laptop. So we'll make sure that you get the slides afterwards, because right now it's a blur. But what you can really see up at the top is there's sort of the different areas of psyches, and it's on my QI report. And this is what most people who have used psyches are used to seeing and they're used to using for various quality improvement projects. We take that Medicaid data and we break it down into different QI measures. So for example, you can see that first one is about the QAR. So the QAR is looking at those HEDIS and CQA measures that managed care companies are looking at, the DOH is looking at, and you can go in and get data for your agency, for your facility, from those QI metrics. And we have what we're looking at now based on previous projects or what we've heard interest in. This is not all the quality improvement metrics we could pull. So if there's one that's particularly of interest for children's programs, residential or non-residential, we can start having those conversations of, does there need to be a specific children's set, for example, of quality metrics? There are some children-specific measures in this list that you can't read, unfortunately. Hopefully folks on the phone can see it a little bit better on their screen. But for example, in the QAR measures, you can look at, see people, kids who are getting ADHD or polypharmacy with antipsychotics, that kind of thing, and use that for quality improvement.
Before we go on, we have a few members here who are on the Children's Clinical Advisory Group, the Children's CAG, and they specifically are charged with identifying some measures that would be used in a value-based payment system. So of what I see here, so I see general medical health. That's definitely one that the Children's CAG is looking at. The other things that they are looking at, but maybe they haven't yet identified the metrics or the outcome measures, would be something like family and parenting strength and capability, or child developmental milestones on track, or was the other one academic? There were 4.
Kindergarten readiness.
Kindergarten readiness. So just out there, if the Children's CAG were to settle on those 4 goals of measuring a value-based payment system, how could psyches help us identify a measurable, something that would touch on through a claim that could be collected, or through CARES or NYMERS or one of the other online data sets? Do you think that you could have a role in helping to identify something that would actually be?
Well, we certainly would like to have the conversation. Okay, and we need to bring in like our technical team. We need to bring in someone like Dr. Finity who's done this for years and years, and see if there's a possibility of doing this. So I would be completely wrong in saying, yes, we can,
Yeah.
but we're certainly open to the discussion, which is really primarily the reason why we're here. Let's start that discussion so we can move forward on something.
So they meet next on May 2nd. And I don't know if recommendations will come out or anything, but it seems like this is a conversation that will happen sometime in 2017. So
Again, with the for
I'm
kindergarten
going to
readiness.
email it to people
Okay.
because I was saying it out of order, but I can do it right now because I share it regularly. And I put it in a speech that I did at the Staten Island Mental Health, and I've cut and pasted it out of that speech a million times, but it's, I'll email it
That'd be
out to the listserv. Yeah.
And we're meeting again this coming Tuesday, as
Yeah.
Andrea said, so very shortly. And I think the focus will be on identifying indicators, milestones, indicators, tools that can be used, what the measurements will be, the evidence-based practices that can be used, screening tools, those sorts of things. I think we're going to be starting the conversation. David is there as well. But the framework is just as Andrea had said, looking at pediatric visits and what happens in those visits, looking at family strength, family skills, but most of all looking at developmental milestones, functional levels of children, things that are moving, and there was a strong focus on early childhood development, so kindergarten readiness, which has been used in other states as a measure of overall health and wellness for children.
Okay. And that's exactly the information that we're excited to hear back from, because, we can pull data from different places, and I'm going to show you a little bit later, we now have some ability to do data entry into the system as well, to begin to be able to aggregate different kinds of measures. So another part of psyches, which actually you can see a little bit better here, is our recipient search area. And you can search for an individual client by Medicaid ID or by name, and I'll show you a little bit later how you can drill down into a wealth of information about that client. But what's really helpful about recipient search is you can slice and dice a population from your agency or from your program in the screen. So it provides you with, it's almost like a crystal report. So it provides you with a number of different fields where you can choose what you want to see. You can choose people between the ages of 0 to 5 or 10 to 14. You can choose a quality flag, which we can add to, of course. You can look at basically prescribers or certain kinds of medication kids are on, or look at different diagnoses, and you can choose what service setting you want to see. So do you want to see your RTFs? Do you want to see your children's day treatment programs? Do you want to see your clinics, children in your clinics? And you can run a report to give you a list of clients with, again, there's a bit of a time lag, about 3 months of billing, to get a list of clients who meet those specifications to start to identify different populations in your agency. And what's great about this is it's not just who you serve. At the bottom, you can also see who other folks serve. So for example, if you want to get a list of clients who are served by, you want to see a nearby agency and how many of your clients they really serve, you can run that list here. So if you're a clinic and there's a residential program and you want to take a look and see how many of your children's community residence clients are served at this place or another place, you can get that information here, and over time.
Can you create reports? It says there's a de-identify tab. Can you get system-wide reports in terms of looking at the population overall, so you can compare the psyches population to your own population?
Yep. So there's a statewide reports area, and you can also do that here through recipient search, where you can run, for example, and look at the population as a whole, and then take a look at what your slice of that population is on different metrics here. And of course, these are fields that can change based on feedback. If there's something that's missing, we want to know about it.
So let me ask an IT-related EHR question. Mm-hmm. Is this the plan, or is this actually doable right now?
To run those reports? You can do that right now.
Okay, cool.
With the caveat that some people are astounded about the pace or the slowness of the psyche system, but we'll just...
So we acknowledge that, and so hopefully we're going to have some resources coming in so that we can upgrade our service as well. and that it will move faster. But yes, it is a complaint that we hear. And frankly, the other day I was running some reports using recipient search, having learned it and feeling very proud of myself. And it was slow. And probably anyone who heard me in my office thought I had Tourette's. So yes, but we're hopefully we have a fix coming in.
And of course, the larger the report that you're running, the slower. Yep. So then we get to the clinical summary, and that's the individual clinical history for any client. And you can get to that either through the recipient search, where you want to put in a unique client's name, or you can get to that from a QI report and drill down into an individual. And you can get all of this information in a clinical summary, depending on what people have billed for through Medicaid. We now also have the ability to include plans and documents that have been uploaded by a provider into the system. So for example, Pat's going to talk a little bit later about the suicide prevention project we're working on with outpatient mental health clinics. A piece of that is uploading safety plans. And you can also upload a discharge summary. So we're going to start working with hospitals to make sure that when they look at psyches for a new client, they're looking at a safety plan if it's been entered. And for you all, if hospitals can upload discharge summaries, that kind of thing. So we're starting to have those conversations and allowing that ability to do the upload. You can upload for a client without consent, but no one can see it unless they have the client consent. So that's the way it's working. It's consent to see information. So that might be a good segue into how you can access this data. There's a few different ways you can access somebody's clinical summary.
Just
Yeah,
some
sorry.
clarification on that. We're all using different kinds of forms. We have different electronic health records. So when we're uploading, you're uploading a PDF or something of that sort.
Yep.
So it's very individual. So that information can't be aggregated. You can't pull information from fields and pull that together. It'll just be on the individual.
Correct. So we also have the Stanley Brown safety plan in there if you wanted to enter it yourself.
Right.
But again, that might be duplicate data entry for people with EHRs, and we're not asking for that. So the way that you can get access to this via consent is a few different ways. One is you get the client consent and you can see everything in a clinical summary. You have to attest to it in the system, but then you also can see substance use history, for example. However, if somebody has a QI flag, one of those quality indicators we showed you earlier, or blurrily showed you earlier, you can see, just because they have a QI flag, you can see the majority of information here because they're linked to your agency due to a bill in the last 9 months, and they have a quality flag. So you won't be able to see some of that protected information like substance use history, but you can see quite a bit of the rest of this. The only other way you can see the data is if you attest that there's a clinical emergency, and you will then have access to this data, minus that protected data like substance use history, for 72 hours. We recommend that everybody consent, just because now, especially with integration becoming such an important part of our work, getting to see that substance abuse history and that history around, for example, family planning is particularly important.
Can you talk about the actual consent itself? Is there a form that we would use as an agency?
Yes, so we have a psyches consent that's on our website, and we can send that out to Andrea, for example, or send the link out to the website. We have it in English and Spanish. And you're also able to put that in your EHR. If you are getting people to consent or e-sign in the EHR, you can just program that consent as long as it has the same words into your EHR.
Great, thank you.
So here's just a very quick example of a clinical summary, what it looks like at the top. Again, it has that wealth of information. So at the very top, de-identified, so it's gobbledygook right now. But you get to see, for example, a managed care plan. You get to see if they're in a health home, any alerts. So we're pulling history of suicide attempts, for example, from NYMERS. So if a new client comes to you and you get their clinical summary, you'll be able to see if they've had a suicide attempt that's been entered into NYMERS by a previous provider. Pretty much, it goes beyond 5 years, actually. We go back until kind of all the NYMERS data. So you can also see quality flags here, and then below you can see there's that plans and documents area where when people start uploading plans, you'll be able to see things there. And then from that on, it's really all of this information. When we get the DHS shelter data, it will be included here, all of that. Now, we're also looking at how do we bring psyches into the modern world. And the way that we're kind of getting this clinical summary on the go. We know that a lot of folks are out in the field and might want to consent a client and look up their clinical summary right there, for example, a crisis team, mobile crisis, or an ACT team. And so we are about to launch our Psyches Clinical Summary mobile app. It's on iOS right now, only in Apple products, but it's going to be on the App Store in the near future. It's going to look like this. And once you can get your token, your Psyches token, onto your phone, do that entry. You can look up a client in the app and consent them right there, or a test, and right away see, this is just a random screenshot, but you can see kind of an abbreviated version of their clinical summary. But if you click on anything, it's going to give you a card like this where you can see the details. So this is an example of if you wanted to see what they, if there was a bill for a mental health clinic, you could pull that up very quickly. We think this is going to help crisis providers out in the field have a quick view of what's going on with the client and their service history, as well as their pharmacy history, which can be really helpful. So we're going to be rolling that out shortly in a crisis pilot, but we're always looking at new ways that could be useful or helpful.
So that's probably where the delay becomes problematic, right? If you're looking for that data, you really want real-time data, and that's really the disconnect at this point. Does that seem correct?
Right. I mean, we can't possibly know if you attended your clinic visit last week if it hasn't been billed yet.
Right.
So if somebody's going out there and they're having a conversation that's about, have you been, what's your engagement? Have you been attending, attending your visits? We can see the last one, but you don't know if that's the last one ever. So that's the last one that we have a bill for. And we recognize that's a limitation with primarily looking at claims data. Unfortunately, only people's EHRs have that information. We also have a part of Psyches that's really client-facing, and it's about client empowerment and engagement, and it's called My Choice. And the My Choice part of Psyches is a place where, just like when you go to the doctor and your doctor gives you your own password to their medical record system, we can give clients passwords. We know that a lot of folks might not have access to the internet or a smartphone in their day-to-day, but even if you're a residential program, they could access things on their computer. And clients can do their own screening. So we have the CSSRS there. So we have screenings for depression, screenings for suicide risk, different kinds of things like that. They can report symptoms and outcomes. And we also have Pat Deegan's Common Ground in there, which is a report that's used for kind of recovery-based and client preferences. We have that in there. And right now, 6 clinics across the state are using that with peers to do the Common Ground report. And one of the things we found in a study there is that it's increased engagement and medication adherence when people are using the Common Ground and really able to see their own dashboards and access their own information.
So on this point, from children's providers, we are not that up to date yet about youth peer being involved in their own treatment planning, right? But specifically for the 1915C home and community-based waiver, the one that we operate right now, once the final approval goes through to continue that program until we transition to health home serving children, we will be adding the 18 up to the 22nd birthday population. So remember that as home and community-based waiver providers, your population is going to change this summer. Like, you're going to be able to keep those kids in your waiver program if they so choose. And something like this is an option to offer those kids especially, because the evidence base is that young people like to be involved in their own treatment planning and understand what's going on with them. And so this is actually a really nice option for people that are initiating something new that you are just as unfamiliar with them in some ways if you're not a traditional transition age youth provider.
It's a great engagement tool. It really and truly is. I've had some conversations with managed care organizations, and they're very interested in this, potentially putting it maybe in some of their reception centers, engaging young people, adolescents in particular.
And I would say especially for our home and community-based program, because we don't have any certified youth peer support people yet, or not nearly enough of them, even though we're still going ahead with changing the population, that this is something you can offer them right away.
Nicole, you may have questions from those on the phone.
Yes, I have a question from Audrey Lafrener. She asked, either sooner or later, what's the relationship between this database and the regional health information systems? Seems the clinical summary, for example, is similar to a clinical summary available for the RHIO. And she clarified sooner or later, meaning to ask the question. Don't need to interrupt the flow.
No, thank you, Audrey. Good question.
So we're having conversations with the Shiny right now because we recognize that there is a lot of parallel work happening with the RIOs and with what's in Psyches. And if there's some way to link data or some way to work together, we would definitely want to pursue that. So we're starting to have those conversations. Had a bunch of meetings in just the last couple of weeks. So we agree, Audrey. There's a lot there. We also know that the RIOs, that not all providers are engaged in RIOs. So for those who are, so there's not duplicate things happening, but for those who aren't, we, of course, always have Psyches. And in terms of the My Choice aspect of Psyches, it might also work for residential programs, even if you don't have peers. If you have a computer kiosk area, for example, people want to do their own screenings and assessments, take a look at their own, their own dashboard that summarizes certain things across time. And we can add screenings and assessments to the system if there's child-specific ones or adolescent-specific ones that are helpful. In addition, there's some clinician-facing things in the My Choice part of the application. You can have your high-risk list, not just based on your own data, but Medicaid data. You can access the recovery library through My Choice, Pat Deegan's recovery library, and there's other sorts of pieces of that application that might be helpful for clinicians. You can even assign people assessments if you want your adolescent to take an assessment every 2 months. They have a smartphone, for example. They can do it themselves on the smartphone, and it can send an alert back to you if it's a positive score.
So I have a question. Can you download your data into an Excel compatible file?
Yes.
Cool.
Yep. All Psyches data can be downloaded into Excel.
Wonderful.
And into a PDF as well, right?
Into a PDF also, yep. Fern?
So 2 questions I have. One is that this is so rich, and it sounds like that there's more to come. Are you providing trainings for line staff, or administrators, and others?
Especially administrators.
This is it. Consider yourself trained.
Go forth and use it. So.
I mean, I haven't looked at Psyches in a while. I know the staff have program directors and others, but I haven't. So I'm really so impressed by how it's developed over time. And eligibility to access the information. I assume it's the same that the agency provides that authorization for who would have access. So program directors, clinicians, peers, if we decide that that's what we want. Because you went through a whole list of those who could access, but we have to provide the authorization.
Correct. It's through the regular OMH security management system that you use for pretty much every OMH system other than CARES, unfortunately. But the same way you have a security manager at your agency, they would set somebody up in the system. They would get a token mailed to them, and then you could give them access to Psyches, and then immediately they could go in and use the system.
So for the My Choice, however, for the individual, how do they get the authorization of access? It's just using their own Medicaid number to get in?
So it has to be first set up between the clinician and the client. So there needs to be some setup where they link the client to, for example, a therapist or a psychiatrist, and they set them up if they have an email address, that whole thing. And then once you set up a client in the system, it will give you, the client will get their own kind of one-pager that explains the system with also their password and all of that good stuff. So
portal access.
It's a portal, exactly.
So Fern, I want to make a point about your first point about how do people get trained, because when Pat and I talked about this presentation and she talked about the slowness of the system, she also,
I work for OMH now.
But you reiterated that familiarity will breed proficiency, just like with any computer program. So having your staff repeatedly use it, you as an administrator asking for Psyches reports to be presented to you so you can see the reports will breed the use of them. I think that part of this presentation is to try to promote the fact that people could be accessing much more data than they believe they can.
So let me honestly say that in all the years at the Coalition working closely with Molly and Psyches, we took more of an advocacy role. We never actually delved into Psyches, nor should we, right? Protected information, we shouldn't be able to see it. When I came to Psyches, I was like the old person having to learn the system. And it is true, right, that it does take some time, but with repetition you really do learn it. One of the things I had heard over the years from providers is, oh, Psyches is still a data dump. And now that I can go in and really look at it and manage it, what I really see is that it has huge amounts of information. It's the ability to learn to look for what you want. So it's not really a data dump. There's such richness of information. It's taking the time to actually learn the system and getting that information and learning to get it out. And then you have like really like a treasure chest of information.
As we're talking more about value-based payments and value propositions and all of that, trying to determine the kind of information, and maybe we can do this collectively too, about what kind of information would be useful that we can use for ourselves and for the outcomes we were talking about, the CAG indicators and that, and to use with managed care companies. I can't even think of all the reports that I would want.
Right.
And hearing from others, to stimulate that kind of discussion. Like, oh yeah, that would be useful. I never thought of that.
I'm going to say
one more question.
Just one more. Actually, it's more of a statement. Speed does become an issue if we're trying to get people to use it more, because knowing and having experience with a system that is slow, it just frustrates you and say, okay, it's not worth my time and effort. So
there's money to address that.
Yeah. We really know.
Yeah, and that's just an equipment issue and getting the right servers.
It does sound easy, doesn't it? If only. Yeah. We feel exactly the same way.
Throw enough money at it,
it'll work. All right. So I'm just gonna move on, making sure that we get to cover everything. A quick coming soon. So I mentioned that DHS information is coming, and also we're starting to launch our mobile application. We're doing a crisis pilot first with Mount Sinai, and we're going to look at who else can use that mobile app. And we know that the clinical summary that we've developed for the mobile app is brief and helpful to people from what we've, from the testing that we've heard, from feedback. And so we're looking to get that much more brief clinical summary into Psyches to help clinicians wade through the wealth of data that's in there. And Pat's going to talk a little bit about the current projects that we're doing, specific around quality improvement.
Well, let me do this quickly because I'm really still interested in our remaining time to hear more from you. So we do have three projects, three CQI projects going this year. There's the Care Transitions Project, and I think actually the thing for me that's really amazing is that there are 340 clinics statewide that are enrolled in a CQI project. I think there are only something like 380 clinics statewide, so you can see the majority of the clinics statewide have seen the value of actually participating in a CQI project because of the hope that it will help with value-based payment, that they'll have successful outcomes, and that it does build relationships with managed care organizations. So the three projects that we have are Care Transitions, the QAR project, the Quality Assurance Reporting Requirements, which is the project that I'm running, so near and dear to my heart, and suicide prevention. So all the projects have launched, and so the suicide prevention project basically is in partnership. It was through an NIMH grant, and it's in partnership with Columbia Center for Practice Innovation, the OMH Suicide Prevention Office, the University of Pennsylvania and State Psychiatric Centers, and of course the goal there is to prevent suicide. The quality assurance reporting requirements are to focus in on those behavioral health measures that the Department of Health has chosen as a quality incentive program for managed care plans. So if managed care plans do well on some of these particular incentives that have been selected by DOH, and there are more than just the behavioral health one, there's a bucket of about 20 of them, they actually can be incentivized at 3% per member per month. So you can see that they are very invested in this and need your help to actually achieve some of those measures. And the third is with our partner at the National Council, and it's the Care Transitions Network that really looks at all-cause readmission and has a particular track for value-based payment. But again, if you're participating in any one of the projects, if your clinic is participating in any one of these projects, it really does help in terms of relationship building with managed care organizations and for future value-based payments. So we do have a fourth project which is going to come to a close in September, and it was really looking at readmission to hospitals. And we saw that for the hospitals that actually participated in the project, and there were 47 of them, there was a 4.6% decrease in admissions. So if you look at it and you think 4.6 sounds very small, but when you consider 47 hospitals and the kind of volume that we're talking about, that's really quite significant. So I moved through that very quickly because, again, I know we only have about 5 minutes, and we want to hear if you have any other questions or comments or thoughts about where we can go as the children's system is evolving, what you might need. And this would, of course, be only the first of discussions that we would have. We would look forward to more.
And that may be answers. Those projects are adult-oriented, the projects you just described?
So not entirely. So they're all for outpatient mental health clinics. But the suicide prevention project, for example, is ages 10 and up, since we know that adolescent population can be a particularly high risk. The QUAR project does have some children measures
specific to children, so we're phasing in the measures on the QUAR project because, number one, there's 6 measures in total, and number 2, we really want the clinics to actually have success, and we know some of this stuff takes time, particularly the 7-day post-hospital follow-up in a clinic, and looking at that heart population that was passively enrolled and ensuring that they get into a health home. That takes a lot of outreach and relationship building and time. So we're phasing in these measures. But later on, there'll be more that'll be even more specific to children, like ADHD medication and follow-up to that.
And also the care transitions is generally for the clinic as a whole and all of their populations. So if it's a child clinic, it's specific to that population.
Jeff?
So I had a couple of questions. One, well, first I'd like to say that it's great to see that this is developed into what it seems to be developing into. It's got a lot of potential for a lot of good information for us to be able to really have a good idea of what's going on. So that's really nice to see. I heard talk about the training, but I didn't really hear about like when that might be and for who might that be available for. So I'd definitely like to, I personally would like people from our programs to be able to really get expertise in it beyond playing with it on my own. I'm planning to go into it and play, but having someone who's really expert and be able to kind of inform us about what we could get out of it would probably be really tremendously helpful. And then the second question was about the risk management aspect that was available for providers. If you could talk a little bit about what that entails, what that would be, what it would look like.
So in terms of access and training, we have a wide variety of things that can be available to you. So we really can tailor what you need to. So there are some clinics or some specific clinics, but there are some programs that just want access. So there's a short kind of access process you have to go through, some things to sign, get people started, and then we have a bunch of recorded trainings available on the website, and we have trainings, we have a number of trainings every month that are offered to you that people can take at their leisure. So if you just want to get up and go, you can definitely go that route in starting that process. However, another way that we approach training is through more of a learning collaborative process. Now I know people hear the word learning collaborative and are like, oh God, not another one. But, we could do it where we get, if there's a group of providers all together that wants to start using the system, we could provide some more specialized training to a certain program type, for example, so we could make it more child-focused, look at the child-specific aspects in the clinical summary, for example, or the data. So we could do something over the course of a few months that's a little bit more focused to a certain kind of program or a provider type or a population. We had a group.
Let me ask you a question. I don't even know this. When Erica does those live trainings, how is that information disseminated, to the field so that they know she's doing it? Because you can go on Psyche, you can see the recorded, webinars. There are actually guidance documents there that could also help you. But those live presentations that Erica does.
Every Psyches user, if you are a Psyches user, you should be getting an email with the list of trainings in the quarter and links to register for those trainings. So you can go through the website, or you're going to be getting an email if you already are a Psyches user that's going to tell you what's available.
Okay.
What's the
I didn't even
website?
know that.
Psyches-health,
at omh.ny.gov.
That's the email.
So you can
What's
go to
the
OMH website.
Yeah.
OMH.
But it's also, I think it's psyches.com or something like that. Yeah, it's like psyches.com.
I never get in that way, so.
Yeah.
You know what would be helpful is if the statewide association could receive some of the some of this training information.
Right. Because a user, first of all, of those sitting around this table probably aren't the users. That's A. Second, across all boards, not just on the children's side, but if it went through the statewide, then we could get that out. And I think if we wanted to do groupings, whether they're groupings of kids providers, whether they're groupings of peers, whether they're groupings of care managers, et cetera, then we would be able, or the associations, we could work with them to do that.
So I was going to ask the question, since we do provider group meetings, would it be helpful to do like an hour-long RTF provider group call where you could walk through a presentation that's kind of specific to RTF, for example?
Sure.
And then that would drill down where the people on the call are really just interested in the reports that would be relevant to people that are managing RTF. And we could work out whether that would be appropriate for day treatment, whether that could be appropriate for, you know, because that might be a nice way to kind of garner our powers together so that
And one for administrators. So
yeah.
Yes. We do have some more. Tell me what you're asking for.
I was thinking along the same lines, you know, like a trainer sort of thing. I'd like to have a couple of people in my agency, so trainers who are really very knowledgeable about psyches and the kind of reports, and then they could be the on-site person and support for other staff where it's a more intensive kind of training and deeper dive than an overview.
Sure, we have actually I think next Monday I'm doing a Psyches for Clinicians training. So we have some that are specific for clinicians. We can have some that are specific for administrators, and we can also, if again you want to do administrators but you want specific administrators for a specific population, we can tailor. And we'd love to talk to folks even before we led those trainings just to learn about what you are interested in and what we can offer.
That might be the best start because I don't know how much we can get and who I'd want to send and focus on, and so maybe
I think definitely as a first step, you know, I like your suggestion. We'll work through the association so we can disseminate the information even further when we are doing the trainings and who it's for, what particular group, and then we can move from there as well. But we do want to get that information out so some people can hear this.
Because the waiver providers, for example, a training on how to sign people up for my choice, and then, you know, I mean, that might be a really good, you know.
So I'm thinking back to the Rio. So even though this is all good and that's all good, the process, the kind of culture change that's required to get people to get used to accessing the data, the process of getting into that system is cumbersome. So the fact that you're talking to each other is great, and at some point the systems can reference each other, or almost, you know, becoming certified in one allows you to access the other. I'm just thinking two entirely different data systems, people just might not, they'll choose one. And I'm thinking, this is more specific to our work in this room.
Well, you know, another piece about the Psyches that I really like, it's free, it's available to everyone. Reels, unfortunately, were not that. And so it was hard for people to get into Rios. And I'm now going through what we call project planning forms for each particular agency. And I'm seeing that while many, many agencies actually sign with a Rio, they don't fully utilize it.
Right.
Yeah. So I hear you.
There wasn't as much relevant data for us for a while. I mean, there were a number of limitations for quite a
So
while.
we were at 10 now.
Can I ask a quick question? Is there much consideration for extending that look-back period longer than 5 years? And the reason that I ask that is as we start to work more with the 18 to 21-year-old population, those of us that are you know, starting to work more with adults, I think it would be intriguing to really be able to see what they had when they were a bit younger, especially if you have a 20-year-old coming into the program.
Okay, thank you very, very much.
Yeah.
Exciting. You know, what's nice is having two people who understand the provider's perspective actually working on this, so I'm confident that you will be there advocating for providers as this thing gets further developed, so great.
Absolutely.
Thank you. This was great. Thank you. All right. So we're not going to take a break. We're going to move right on.
And we've already done the first part, which is the welcome and introductions. So we don't need to do that again. But I'll go into my report. Is that
Let me open the
okay?
other PowerPoint.
Okay, we'll wait.
So look, both our logos are on the power.
Nice clap, nice clap.
There you go.
It does.
To make a commercial.
Oh, wait. All right, we are on to the President's report.
So it's been a very busy couple of months. We've had a meeting with OMH. We've had an update on the children's MRT. And we've also had, during this time, the finalization of the budget. So what's unusual is there's a lot of good news out there. So we'll talk a little bit about that. But first, in terms of the children's MRT and the whole transition to managed care. So Jason Helgerson joined the children's MRT March 14th meeting. And as you can imagine, there's a lot of confusion about what's going to happen next, because nobody really knows what's going to happen next, and really trying to get a sense of the environment at CMS. Now, under most circumstances, this would be a typical change of, executive leadership. I think with the current administration, it's just a mess.
What are you trying to say, Jim?
I'm saying nobody really knows what's going to happen next. And I'm not even sure people at the West Wing know what's going to happen next. That's just me. But anyhow, DOH is really being very cautious. They are not looking to push anything at this time because they do not want the CMS to look at the whole 1115 waiver. But they are concerned about new services being rolled out when they think there may be a significant cut to Medicaid. And they're beginning to gain confidence that CMS won't use the waiver as a way to drive other policies and the federal match that won't be disruptive towards repeal and replace. So it's my understanding that currently all the time frames that are on the website in transitioning to managed care are still the time frames, but everybody's saying nobody believes those are the time frames, and they don't want to change them because they don't know what's going to happen. And so, we're stuck in these are the time frames, you want to think about them, but nobody believes those are the time frames. Is that a fair?
That's about it.
And I think that what Jason was saying is they're going to take another month or two to keep their ear to the ground. Repeal and replace didn't happen. Now, he came on the call that the repeal and replace didn't happen on a Friday, and this call was on the next Monday or Tuesday. So everyone was happy, right? But it's still not clear what's going to happen next and whether the Medicaid match is state shares and all of those things are going to change. And he did bullet out concerns specific to the fact that our 1115 waiver amendment is an expansion of a benefit. It requires more spending, and they have to be cognizant of the fact that they're not going to submit something that expands spending if they see huge budget cuts related to Medicaid. So no change in the time frame, but clearly nothing's going to happen in October. Nothing's been submitted to make any changes. So I just would hope that the coalition can help people understand by giving reports like this, like the next earliest time that we may hear anything about our waiver is June 14th. All right? So let's not ask any more questions about time frame until June 14th, and then we'll try to give you an update. I mean, it's the best we can do, and it's horrible from a budgeting perspective for our providers. Horrible. I mean, you can't guess anything about new services, old services, reimbursement, or anything like that. And to the extent that the coalition can be helpful with that, that's our goal. to try to give you as much information to keep you operational as possible.
Okay. And so the other thing I want to talk a little bit about is we did meet with the Office of Mental Health, and a lot of the material specifics of that discussion will be dealt with throughout the rest of this agenda. However, it's important to know that, one, we're advocating strongly on your behalf. Number two, OMH, again, is powerless because it is not driving this bus.
Right.
DOH's and, more importantly, CMS's right now. And so there's a lot of dancing going around, making sure that we get as much information as they have, and they're very transparent about it from what I can tell. I think when we talk about the HCBS waiver services, I think Meredith has been advocating very strongly on our behalf. And I think the bad news will be the things we'll talk about. The good news is it didn't happen sooner, and really was holding this off and had been holding it off as we are preparing for health homes serving children. And with all the other things going on, that really is now, we can't use that anymore, and CMS is moving forward, but we'll talk more about it. But it's a very challenging environment, so that's and so the other thing is that the budget was a very good budget for kids. It was very good budget for children's mental health. There was $10 million specific for children's capital, and again, we'll talk a little bit more about that. There is money for workforce. There is pilots for RTFs. There's $5 million money that was set aside for pilots. There's $75 million of new healthcare facilities transformation funding. There's $20 million for new nonprofit infrastructure funding. And for many of us, the biggest one is that the OMH government rates have been extended to March 31st, 2020. Now, there's a caveat on that in terms of showing movement towards APGs, but I think that's, and we'll talk about more, probably not a bad thing considering we really want to be part of any value-based payment discussions. So, and then the other thing I want to say is that Andrea and the coalition has been working collaboratively on a lot of these items. We're with 11 other behavioral health organizations on the workforce funding. We've been working with families together on a lot of different issues, but the children's capital funding. And so the collaboration that was really an important part of the board's strategic plan has been implemented in a very big way by Andrea and Jackie. So I think we can feel good about the results of the budget for kids services with a big caveat. The caveat is this, is the governor put in the budget that if for some reason there's a reduction of federal funding greater than, I think, $65 billion?
$850 million.
850,
which isn't very much.
850 million?
Yeah.
That the governor can basically turn things and say, listen, I'm going to make my own cuts. Now, you know, here's my own perspective on it. Most of the things that are going to be driving this won't be done until the current federal budget, which is really October 1st. So, you know, there is a good chance that those kind of cuts that we've seen in the federal skinny budget that Trump has released or the Medicaid cuts probably won't happen in this current year. And, you know, but again, that's my own editorial. But anyhow, Andrea?
No, I think that basically those are the facts of what we've heard from Jason, what we heard from OMH at the most recent quarterly meeting that the New York State Children's Coalition had with OMH. And, we'll go through the details of the budget so that you know when to expect this new money. And, we're not naive. There were cuts in the budget for foster care, and there were, some vetoes. There was the governor line item vetoed the workforce money for the special act school districts. I don't even know what that was about, but anyway.
It's a snack, New York City.
I know, and I don't represent those things, so I know about them, but I don't always report to them. But from our perspective and the coalition and the colleagues we worked with, there was more response and more money on the table at the mental health table than there was at the human services table for kids. And that is new and different, and what a breath of fresh air, honestly.
But I also think it was a strategic decision where all of the coalition was not looking at new funding. They were looking at what should be funded, that should have been funded in the past. So that strategy, when you went up to Albany, there was more reception, more of the government that was receptive, because we didn't ask for the sky, we asked for focused funding that was already discussed. There was nothing new. It was like, just give us what is our due based on previous budgets. And I think for all the coalitions getting together, we had that kind of impact.
Right. And so one of the things I'll pass around is a thank you that the coalitions that advocated together did in City and State Magazine, where all our logos appeared together. So, hopefully this is the beginning of a long history of doing stuff like that around single issues.
Well, and honestly, though, the collaborations were important, but I am going to give a special shout out to Andrea, because she really was doing a great job advocating with us. And for the first time, probably, the chair of the Assembly Mental Health Committee, Aileen Gunther, really talked about kids' mental health. And that's huge. She basically said, yeah. So she was on the radar. Good news, bad news is Andrea has a good relationship with the Senate chair of mental health, Senator Orts. That's the good news. The bad news, he's under indictment.
I kiss the death.
Because most of them always are. I know. We got to keep up our relationship. So I'm going to move on, and I'll give you a quick update on where things stand on the specific funding stream so that you know what you need to do. And when I get to the Senate and the issue of the statewide health facilities, I did get a very positive message from people in the Senate other than Senator Orts. So I think we're in good standing in general. So kind of a last minute thing, because it wasn't included in the governor's money budget, it wasn't included in either one House budget proposal, was the fact that the Human Service Council's lead for the nonprofit infrastructure capital improvement plan came through with a new $20 million. Now, I reached out to Allison Sesto yesterday to find out what she knows about where this money is, and I had emailed my own contacts at DOB to find out what's the plan, when do they think it would be released, are they going to change the purposes, are they going to go down the list for projects that didn't get funded from the $100 million last time but were scored high enough to be deemed eligible for NICIP. Nobody knows yet, but I'm working with Allison to keep on top of that. So this is an item that I will continue to keep in updates for our members. On the $20 million OMH Children's Capacity Building, this was 10 million. I'm doubling it. 10 million. This really was a response to the fact that there was a $20 million cut for children's readiness funding to help backfill the VAP clinic state share when the feds backed out. So just so that everyone understands that, I'm just going to go through it again a little bit quickly. There were 40 clinics that got vital access provider funding. The feds declined to do federal financial participation with those VAP grants very late last fall. And that put the VAP program at risk. And OMH felt strongly enough that the VAP program needed to go forward, that they and DOH found $50 million, which constitutes 1/3 of the amount that the VAP clinics would have gotten from federal match. Only 1/3 of the federal match. They're going to pay out the state share, and they're going to pay out an additional 1/3 of the federal share out of state funding. And to do that, they took our money. Now, DOH was livid at me when I said, nobody took your money. We're continuing a commitment in the out years to give you that money eventually. They took it this year. There was no money for us to do more readiness work for managed care. And, you know, that's the way things happen. The VAP clinics needed the money. I mean, this was a huge cut, and many of my members are VAP clinics. So I'm not going to advocate against myself, right? But I made a big stink about it, and we got $10 million in capital money because of the stink. All right, so good for us, right? Now we have to figure out what we want to spend that on, and I just want to spend, you know, maybe 2 or 3 minutes. The $75 million for statewide health facilities is available to clinics. So I'm not inclined to have clinics be eligible for this $10 million. Is there anyone that feels strongly that that's not a fair assumption?
But before we start, Emil was pretty clear, because this is going to be bonded, that it probably needs to be significant grants. So it's not going to be smaller kind of $50, $100 million grants, $100,000 grants. It's probably going to be $750,000 to $1 million. So there's not going to be
really wanted, because it's bonded, for it to be like $10 million projects or, you know, 15, you know. So where's the need outside of clinics in our system? And he didn't want me to put CRs on the table because he said that he has capital money for CRs. We have to shake it loose, clearly, because it's the first time I've heard that in a long time. But, you know, including people on the phone, are there opinions? Because this is something we are going to have to get back to OMH about relatively quickly. One of the things that we discussed, because the future of day treatment is so uncertain, I don't even know how to describe it. You know, is there something that day treatment providers would want to do with their physical space that would be an alternative program? Convert to partial hospitalization, convert to some other type of clinical program?
Any of I heard from I think I was talking with Lisa Clark. She said that the worry about change in the reimbursement, because we were all worried about that. She said that they've gotten past that, that they're going to continue reimbursing us, at least for this period of time, the way they have for the children's day treatment program. So that's, you know, that was reassuring. But in light of all the discussions that we're having, that's who knows how long that's going to last. But right at this moment in time, there's no plan to make any changes.
Right, and I am going to address that. So we're pretty good on day treatment until 2020. We have this government rate promise and so on and so forth. The problem with day treatment is the transition to Medicaid managed care, and OMH is pretty clear that they don't see a clear path. So I'm not going to candy coat that, right? I mean, we are working with Lisa Clark and OMH to identify alternative school-based funding to try to promote non-stigmatizing BOCES, you know, based education funding, using community school funding to push in mental health services, doing more school-based mental health clinics. Those options, day treatment, providers need to think realistically about the future of day treatment. So that's the only reason I put that one on the table. What I would ask, since I don't know that we're going to get a lot of feedback, is Nicole. Nicole, do you have any feedback?
And if it's essentially close to $1 million.
$1 million project.
So it has to be
bonded capital improvements.
Yeah.
So think about that, and please provide the coalition with your ideas about what you know, your priorities would look like, and we will share for that.
The only one that comes to mind quickly for me is integrated health space.
Right.
To meet Article 28 requirements to be able to provide both primary care, pediatric services, and mental health services is very costly.
And we completely put that one on the table, and Emil said, yeah, but they can apply for the $75 million, so why do we want to use this $10 million for that? Article 28 can apply for the 75. I mean, I'm just saying that in parsing out the choices.
So if you're talking about $10 million and $1 million, you're talking about 10 projects.
Right.
Not a lot.
So where is our priority?
It's not a lot. I mean, that's
It's not a lot.
And I think OMH thinks if there are RTFs that are looking to convert their beds to something different, there may need to be some capital money to do the physical renovations necessary.
because the $5 million is more operational.
It is.
3 years,
$5 million.
right? Yeah.
With
Well,
mobile teams, home-based mobile teams, school-based, home-based mobile teams, and buying vans, hiring, can any of that go towards staff capacity?
We had raised vans, but we didn't get an answer.
Yeah, they said they have money. And again, it was pretty small. They were looking for bigger items because of the bonded. It was going to be through, I think, the dormitory authorities.
Go ahead.
The lumber construction is not for staff.
Not-
Bonded money, and I think this is where there probably is some confusion. Bonded money, first of all, is expensive. Every project costs a lot of money to be bonded, but it also, under the Internal Revenue Code, there needs to be a particular period of time that project, the integrity of the project is protected.
Right.
That means the bondholders, the people who buy the bonds, their investment is protected. So it's usually anywhere between 11 and 15 years. That's why and most of the bonds are like 25 and 30-year bonds. I'm finding it's amazing that they're looking to invest $10 million in capital that they're going to tie up, theoretically, for 30 years.
Right.
And I'm just wondering, is that a strategy that we all want to, I mean, I don't know that many of us in this room are going to be here.
And our services may or may not, right.
And I think that the problem is, we really need district money. That should be $10 million of, like, not bonded money. Because we need the ability to have money to help change our facilities, from whether we go from residential to whatever. But having it bonded means we are buying into a structure that I'm not a crystal ball, but, you know, and who'd have thought 30 years ago that we'd be sitting in this room with a question like this. But I would really consider going back to them and saying, I don't know that this makes sense from their perspective or from a provider community perspective.
I think that to OMH, I mean, just to defend their position, and I didn't want to present it as a fait accompli, they feel like the RTF got left out of the transformation capability, and that they think that there is a reason to transform those buildings into
not through bonds.
Other purposes.
Because the bonds are, the way the bondholders get paid is through the revenue that's generated. So
No, this is actually the state's going to pay it.
Yeah.
So that's the beauty of this. It's their,
It is our problem, it's the open program.
right.
If the program closes, I mean, the state's the one that...
It's the state's money, this time, in this small example. But we have to work through those details, definitely.
And that's a great question to
Yeah.
ask Emil. and
He
see
was
what he-
hinting at that, but
Yeah.
That
And I think
programs weren't on the hook. It was,
that it's they're
Yeah.
the ones assuming the risk,
Yeah.
not us.
Yeah.
So let me just go on the $75 million Healthcare Transformation Fund. The language that appeared in the budget is similar to the $30 million that was available last year. And an update on the $30 million, if you applied last year for the money for the statewide health transformation, the word on the street is they are ready to release those projects now by May 1st. So this week is the week.
Yeah.
I mean,
My birthday. Happy birthday
I know.
tomorrow.
And what happened with the negotiations were that there is 500 new this year, and 300 of that 500 will allow DOH to continue down the list of whoever applied last year. So if you applied last year, not only is there last year's 30 million, but there's kind of a lot of money that they can go down the list because they didn't differentiate between the 300 about whether those had to be for community-based or for hospital. And we don't know how that breakout would go. Then there is new money, 200 million new, 75 million, a minimum of 75 million has to go out again to community-based organizations.
Not just children.
Not just children, it's FQHCs, it's Article 28, it's Article 31s, it's primary care, and there was new language put in that the commissioner can add other eligible applicants based on legislator, community, and stakeholder input. Now, my asterisk here next to getting stakeholder, legislative, and community input is that I was told yesterday by the Senate Finance Committee staff that that language was put in specifically because of my advocacy around RTF, that they were committed in the negotiations to make RTF eligible for this statewide health facility transformation fund this time, but what happened was at the last minute, the gates opened and 7 other strong advocacy organizations came in and wanted to be included as well. And they did not have time in the last days of negotiating the budget to go through and weigh the merits of every one of those, which included the developmental disability ICF providers who statutorily, federal statute, have to convert and downsize their facilities. So rather than completely leave us out, they gave us a job to do. If you have an RTF, you need to contact me, and we need to get your senator to ask for a meeting with Rob Orr, so Rob Orr can write to the commissioner with your local state senator, and we can get community stakeholder feedback, letters from assembly people, letters from families. If you need money for your RTF and you really want to go after this, we have work to do. But it's doable, and it was intended to be for us to do it.
Andrea, Audrey, I think.
Yep, Audrey. Nicole, can you unmute Audrey? I think it's easier.
Yes. Hi, Audrey. I have unmuted you if you wanted to make your comment aloud.
Okay. Good morning. Actually, my comment was I wrote it back to the $10 million ask, Andrea, that you made about sending our priorities to you. Yep. I was just asking, by when do we want to do that so we can organize them?
I don't know that OMH indicated to us by when, but I think sooner would be better. So maybe by, say May 15th. Give people a week or two to think about it.
Very good. That's it.
Yep. So moving on to the 55 million workforce revenue, again, you'll have to, just like the last time when we got the 2% increase, I just have to ask people to go back in your memory, right? We got a 2% increase. It went in the first quarter of the fiscal year to the direct care staff, and then in April, it bumped up again, the direct care staff, another 2%, and then it added the clinical staff for 2%. This year, similar way, we're going to get 3.25% bump up of the direct care staff for January to April. And then in April, you'll get another bump up on those 100 and 200 lines, but you'll get 3.2% on your 300 clinical line. 2 things to remember here. You will have to document that somehow that amount of money was spent on salaries and fringe benefits on staff. But it is revenue generating. So you are going to get that bump up on your Medicaid rates as well. And so it is much more than $55 million in total statewide. The estimate that I heard statewide is that the out-year tail of cost to DOB for this was $146 million across the 3 O agencies. And my calculation was that it would generate $6.75 million from January until April, and over 17 million for OMH agencies from April to March.
How does it do that, Andrea? How does it bump up the Medicaid rate?
On those lines on the CFR, if there's any matching funds that come in to the state, then that 3.25% becomes 7%.
It raises the rate.
Yeah, it raises the screen.
Wouldn't it be different for every agency?
I mean, I think that it's probably different, but in terms of the amount of revenue that gets generated when OMH calculates it system-wide is kind of the numbers that I'm talking about. But you could probably figure out from your CFRs, when you raise those lines by that amount, how much more Medicaid revenue would that generate for your individual agency? No?
And what would probably happen in years
You
past,
would have to raise the screen or
usually the rate, example, let's say you get.
In the RTF, I think Amos made the commitment to raise the screens. For the clinics, I don't know.
In years past, it would.
I don't know how you do it on the clinic. Right. That's why I think that would be.
Yeah, there's no screens, it's just the Medicaid rate.
Yeah, what happened in the
APG
past.
rate, it's not screen. It's for a residential program, it's not for.
It would just raise, like example, you're getting $100 a session, let's keep it a round number, then all of a sudden it went up to $103.25. I mean, that's the only way you could do that.
That's the APG rate. That's
Yeah.
not the screen.
Yeah, but that's the only way to do it.
So we can go back and get, we'll go back and get a clarification of how it will generate the revenue money, the additional Medicaid revenue, and how OMH will get it to the providers, okay?
Right.
But my understanding is that that's what happened last time, no? When you got the 2% and then it became 4%, it didn't change the rates at all.
Okay.
So just on the state aid contracts, you got it?
Yes.
Not on Medicaid?
There's no mechanism.
Yeah.
I don't know what the mechanism is.
Okay.
Just think about it, we're all on Medicaid managed care plan with our clients. So, on a community basis. I just want to have the NCO then, they negotiate a rate with us, it's the APG rate, sometimes it's an enhanced rate. I think it was dollars that came, looking at the CFRs, it was dollars that came directly.
Yeah.
It had to, if they did it as an enhancement to the Medicaid rate, you get to the cops problems, you get into lots of other sorts of things, and it would be uneven. It wouldn't be.
So when it happened last time, did you get a state aid net deficit funded payment to cover this?
The clinic.
Not for the clinic.
I mean, it's part of the claiming process.
Yeah. Okay. I'll get some mechanisms about the specifics for each program. You know, I know how it'll work for the RTF. The $5 million RTF pilot money is going to be state aid. We'll talk a little bit more about this later, but your agency is going to have to decide whether you affirmatively want to be participating in this or not, and that's going to be the first step. OMH is going to reach out to each one of you, and you're going to have to attest, sign, I want to participate, I don't want to participate. So we'll talk in details about that. The $3.5 million for minimum wage increase, which is also in Medicaid, so that money you would have gotten from when the minimum wage increased January 1st, 2017. How did that get distributed? It was $1.2 million, so it wasn't a lot of money statewide. Do you know where it hit your rate? This year it's $3.5 million. It'll go into effect January 1st, 2018.
Again, it probably, like ICF rates are all individually determined, like RTFs are. So they're agency and program specific, as opposed to the clinics that are APG straight, which everybody gets pretty close to the same thing, you know. So any program that had individually determined, developed rates, you could continue to do that in various ways. For those programs that are sort of more uniform and APG driven, that's a whole other animal.
And pros and cons is a nightmare.
Yeah. All right. Well, I'll get clarification on that funding money, but I think the bottom line is for the fiscal year that begins, if you were to do a calendar fiscal year, January 1st, 2018, there will be new revenue. The question is right now on the table, how will you get it? And we'll get an answer to that. All right, this is an update to what Fern alluded to. CMS has threatened no further financial participation after September 30th for programs, OMH programs that had not updated their state plan amendment descriptions. The children's programs that were impacted or threatened under that were day treatment and community residence. OMH reported to the coalition that the rewrite for the children's day treatment is going very well. They're almost ready to submit to CMS and initiate negotiations over the rewrite. Providers do not have to be worried. It would be very minor changes and documentation and descriptions about what they do during the day for the kids in day treatment if the proposal that's been drafted is accepted. But, and this is the caveat we were discussing, OMH still believes the day treatment redesign is necessary and that we need to strengthen the connection between state ed and the BOCES with the providers to move forward into a new paradigm of school-based mental health or educational support going forward. So the coalition will reinvigorate our day treatment efforts, and there's a lot going on in Central New York that OMH is involved in, and I met with the State Ed Associate Commissioner who said that she, more than ever, is working as a result of the community school money with new designs of centralizing services through BOCES to support kids that need mental health services. So I think that we're moving slowly. What is the residual day treatment look? That is going to be the million-dollar question. For the kids that really can't function in any of these other models, what is it that anybody has in mind? And there isn't an answer to that question.
Well, and working with Lisa Clark to get her to understand the value of day treatment, because right now she doesn't see it as a valuable service. She thinks as a separate standalone, it really is not in the kid's best interest. And so I think it's important to really begin to have those conversations with Lisa from all different angles to get her to understand it. I think she has good, valid points. The problem is day treatment has always been all over the map. It's not always clear to me that the model that was developed is a good model. So, I think we should, A, listen to her, but also try to get her to understand under what circumstances doesn't seem to make sense.
I think it's a discussion about if people want day treatment to be retained as a Medicaid service, we have to break with our support of transitioning to Medicaid managed care for some programs. If not, we're not going to transition each one of your individualized model of day treatments to Medicaid managed care, because you would have to sell your 10 plans that you're going to participate in with, paying that rate. So I just think it's a little bit of a departure from where the coalition has been, which is that we support transition to Medicaid managed care. We may have to modify that with an asterisk, except for day treatment.
Well, and OMH has in fact carved out currently the RTF and day treatment from the transition.
I think that's till 2020 or 2021. So
I think that gives us a little bit of time to do some thinking. My brief discussion with Lisa was around something else, but this came up. She talked about your program. They asked her to go to the schools, and I don't know a lot about it. I'd like to know more, but she was advocating that and learning more from that. Clearly, she was saying that she wasn't as knowledgeable as articulate about what's happening within New York City, but Long Island, and then the rest of the state. She said the need was pushing into schools, just as you said, and she is looking at models that bring the kids to school. Right. So, and then the other thing is that there are just so many different kinds of day treatment programs there. We can't talk about day treatment, you know what you're talking about.
That's the real problem.
Because I think that that's...
We're trying to fit everything into one peg, and it doesn't work.
Because the managed care programs are going to say,
Right.
I'm going to pay you for this model of day treatment, and then if it's not your model,
So what we're finding,
what do you offer?
We're piloting spa services in Oswego County as part of the transition of day treatment to services based in schools. And Jim, what you said is right on. She doesn't acknowledge that any kid needs a milieu, you know, even if it was for even if it was for a limited period of time. It would be what's happened in our discussions when she speaks with the BOCES is then they come and say, what you do is pretty much what we already do also with kids who are special ed. We've lost our ability to articulate specifically the needs of kids with SED and the nature of our mental health services. We have to get better at articulating that system-wide because it's getting very watered down.
So I'm wondering whether we should have some pointed meetings just about that.
That would be very
Both
helpful.
day treatment providers, but clinic providers are going to be impacted by this as well. So anybody who has an interest in seeing what's going to be happening at day treatment within the day treatment deal, she started spewing off all these different models for structured payment, integrated and not integrated, and I got totally confused with what she was saying. I think we need to have a real
that would be very helpful.
on that person and see what, and separate from that group, you know, for those of us who were part of that work group a couple of years ago. I think we have to have our internal,
right.
But I think there's a major silent voice in this process too. It's those BOCES that want to move to something that have been trying to get towards a day treatment program for a number of years, and mental health has said absolutely not. We're not even willing to entertain that conversation, which they're doing creatively with mental health organizations. But you know, if you started asking the questions of number of BOCES and communities and districts around the state, I think there would be a louder voice than just those existing districts and BOCES that are paying for these.
Here's what basically Lisa's, her models have other people paying for it, particularly BOCES and school districts, so it's easy to create these, and she doesn't believe that you need a license to do this work, and so when we've had this, I've had a conversation.
No. She doesn't believe that you need a license to do the work for non-Medicaid kids.
Right.
Right. She wants to stop day treatment providers who have only 40% of the kids in their day treatment program who are Medicaid eligible from trying to, well, a lot of upstate providers do.
Yeah.
And they're trying to spread the Medicaid money across non-Medicaid kids. And what she's saying is, call it something else, do the same thing, but get a grant from BOCES to pay for it for the school kids that go to school that are not Medicaid eligible.
Or bill on a fee-for-service basis.
A grant. Yep. Not even managed care. She says don't do managed care. She's saying go to
the school
district.
That's exactly what she said. Yeah. Then that's our model. Both the states on Medicaid.
But then at the same time, the BOCES are saying then don't ask questions after the fact. If we're bringing in psychiatrists and we're bringing in therapists and trying to, if we're using our dollars at that point, then don't come in and try to micromanage and ask us questions.
It's further about the credentialing and the corporate practice of medical issues, which are separate and apart from licensing and billing. Those are medical issues.
And that's if you don't have a day treatment license, they become a problem.
So if you're doing it without a license, there are regulatory.
And that's the issue that I'm bringing up, and it divides a bigger wedge, and we're trying to bridge the conversation between the Department of Ed and Office of Mental Health.
Yeah.
And the BOCES are being, turned away from by the Office of Mental Health. Then it just drives that wedge.
But your point about credentialing and corporate practice, are you saying because of managed care contracts, or you're saying just because hiring professionals? Yeah.
What the license does, if it gives the program the ability to provide service.
Right.
If there is no license, or no license for selling apples, and you're selling apples, you're either existing on the license of the individual practitioner.
Right.
So it becomes a very, you just need to know what universe you're in and what the rules
And so one of the ideas that I have to address this, and one that I would like to see if people are interested in exploring more, is the concept of a limited license practice, that you create a practice under a separate corporate, as part of your corporation, where you hire licensed professionals, where the weight of their license is the credential, but you are doing the back office billing. So a practice, a licensed marriage and family therapist practice, or a licensed mental health practitioner practice. Captive PC. And are others familiar with the captive PC concept? And does that start to get to some of those concerns? Because I would like to bring in professionals to talk to people about that.
The job is expensive to do and monitor and maintain, so there would need to be a critical mass of business.
Right.
For an organization to make it worth its while to set up.
So one of the critical masses of business could include, and I'm just saying, a menu where you have private practitioners. They work for themselves. They're not your employees, so to speak, right? They're in a private practice. They pay quarterly estimated taxes. They, off of a menu of services, you could contract with them 1 day a week to be integrated into a pediatrician's office, 1 day a week to be doing, and 3 days a week to be day treatment, light on the contract with the school district. And that is their 4-day work week, and they're happy with that, and they're a private practitioner, and
they do the back office.
And you do the back office. Or you could subcontract your intensive in-home for your home and community-based waiver through a captive PC because you're no longer making enough, and through the waiver reimbursement, and so that person is on call, and that's the career that they are interested in doing. I know that that's kind of out there because I don't know how many people want to do it, but this would be the power of a captive PC, and I think that it's a business model that the coalition members should, if you're not interested in it, just tell me, but if you are interested in it, please indicate to me, because I would be happy to bring in a guest speaker who could talk to us more about how a captive PC could work.
It's probably worth doing that and not talking much about it because it gets very complicated very quickly. Yeah.
I just want to throw in those of us who have unions like 1199.
Yeah.
That
no, not an option.
Well, but let's have that conversation separate, because there's always another fly in an ointment to make it a little bit more complicated.
All right. The bad news on the CMS letter is that the children's community residences.
Yeah, I thought we were going to do good news.
I know. There is that.
Not the good news.
The children's community residence state plan rewrite is going to have to be significant because the CR current description does not meet rehab service standards. It needs to be completely overhauled. So right now, if you operate a CR, you technically are at risk of losing federal financial participation September 30th. OMH reassured us that because they intend to rewrite all the other state plan amendments, they are confident that they'll get an extension on the CR rewrite from CMS. So let's go with that positive news. The rewrite will include an array of things, including not being a monthly rate, it'll be a daily rate. In that daily rate, there will be a breakdown of the services that are eligible to be billed, and they have to restore the youth to prior functioning. They can't be about maintaining current functioning. This rewrite was done for the OPWDD group homes. I asked for that rewrite and program description to be shared with me so I could share it with our CRs so you could get an idea of what it's going to look like. And I haven't gotten that yet from OMH, but I'll do that, make sure that I get it to all of the CR operators. And I'm sure there might be questions about this.
Rehabilitation to what? Treatment model with children and development, your psychiatric treatment and maintenance.
If they previously were able to attend school, you are trying to restore them to being able to attend school.
At all.
That's why we need more time to do the rewrite, because we need to be involved with them. They need to be involved with us. They haven't even reached out to you to tell you this, really.
No.
Okay, so is this applicable to all CRs?
Adult and children.
Because there's the rub, right? That's the problem. With an adult, you talk about rehabilitation. With kids, you're talking about habilitation and skill development. And so that's always the problem with putting the two together.
What do we want to do?
Well, I think we look at the OPWDD because, in fact, it may be appropriate for kids.
I'll get those, and then we'll do a CR provider group call. All right? I'm going to run through this quick because we've talked about this a lot via email, but OMH had always agreed that the TCM providers, when they transitioned to health home serving children, would be held harmless for their revenue. That they would do a reconciliation based on high, low, and medium acuity, and that you would be paid quarterly for whatever you were owed to hold you harmless for TCM, and that this would be done for 2 years. So that was the promise all the time during the transition. In January, we heard for the first time that DOH had decided that TCM providers, former TCM providers, would not be reconciled for December and January, and the first quarterly reconciliation would only be for February and March. The coalition immediately raised a red flag that this was an unanticipated loss of revenue that people were planning on, and then we came to find out that 75% of the TCM providers had fully complied with stopping billing the eMedNY TCM rate codes, which you see on the bottom of this page here, and had converted their entire legacy population to health home serving children. Now that means 25% of TCM providers had not. That's about 22 providers, but 80 providers did it. So OMH is, no, it's not OMH. Sorry. DOH is penalizing the 80 providers who did a good job at the expense of the 25 who dragged their feet. I have no idea who the 25 are. 22 providers are that didn't, that continue to be billing eMedNY for TCM. I don't know if it's because their cases refused to go, Jim. I don't know if you know, they couldn't convince the families to go to the other service, but I don't know why then you didn't discharge them.
Well, I'm not sure. I bet we did discharge them. I'm not convinced we did continue to bill Esther. You know, we lost a lot of kids and families in the transition to health homes, which was unexpected, actually.
Yeah. And is there an issue of, I remember, and I may have this wrong, but TCM billing, the cycles being different, and I'm wondering if, at least for December, right?
I'm willing to concede December because there was a continuation
cycle. Health bills down to the first of the month. TCM bills November at the first of the month.
January, I don't even get it.
Yeah.
So what?
I don't know how you could. Yeah.
And the range of data that I've collected so far is that we have, you know, some providers that made out. They did make money. They wouldn't have been reconciled. We have one provider that could lose as much as $45,000. The average of the 5, 2 upstate and downstate, was a loss of about $12,500. That's significant. That's a month's worth of revenue. We are operating on cycles of revenue with like 2 weeks of revenue on hand. So this is not something that I think we should just concede. OMH at the quarterly meeting agreed to put it on the table with DOH at the May 2nd Behavioral Health Provider Association meeting, so I'll report back to people when I hear what DOH says. Subsequently, I sent an email to Lana and Colette to ask them to reiterate what their reasoning was for why they changed the reconciliation rules, because, you know, and pointed out that if it was just because there were still people billing eMedNY, then don't reconcile those 22 providers and reconcile to 80 others, right? So,
and one of the solutions they may come back with is instead of looking at the months, they'll look at, 6 months or a year, and if you lost revenue over that period, maybe they'll look at it.
but that's not the promise. The
Right.
promise was quarterly reconciliation.
Right.
So if every time DOH says something and then they change it, then I do think that we start to have a
Right.
communication issue.
Right.
And I think that's the point that I'm willing to bring on your behalf.
Andrew, that is actually what they do.
Yes,
I
I know.
in the respect that
Yeah,
you've
right.
been a little lucky in living in an OMH cocoon.
Right.
I can't stop saying that. The DOH actually does do that. They-
Yeah.
Particularly on the conversion of adult health, promises that they've made. So part of it is how do you develop a plan, like a plan B, if the promise doesn't come through?
Right.
Because they are notorious for that slip slide.
I will be stating that in no uncertain terms on May 2nd. And I think that there are others that I've kind of staged up to back me up on this, especially the children's transition, because we haven't even started and they pulled the rug out from under us on outreach too. So it's like we just started. You cannot lump us together with the problems in the adult system. We have a completely different legacy rate reconciliation than the adults did, and it's not nearly as generous. So don't change it arbitrarily.
I think my point is that we're all sitting in this room
Right.
with a historical approach and experience when a word was given to us by a regulator. It actually matters. And our experience with DOH in terms of adult health is that they say something and then you really have to fight and maybe get it.
Yeah.
And there is no rationale for the change. So
I think that we fight.
Rationale. They may not
Right.
articulate it, but they.
Or it may not have anything to do with providing.
I just want to urge people that the kids system needs to be prepared from step one. So every time they do this, they're going to get a needle in the eye. Even if it's, we have to do it because otherwise we will be lost. We're such a small voice.
Right.
I can be the most obnoxious person in the world if I have to be. David, can you attest to that? and I'm willing to do it because they're going to say, oh, $12,500, big deal. And I'm going to say, in our cash flow, it is.
It's a big deal.
All right. Any questions to date? Jackie, anything? Nicole, anyone raising their hand?
Now comes the real band.
Okay.
That was just kind of the good news and maybe not so good news. Here comes the really bad news.
I want to do the waiver and then we'll take a break for lunch, okay? But
For those that are still breathing.
I know. I want everyone to take a deep breath. Everyone, we're going to calm down. I'm going to talk in a decibel lower than my regular voice. I want to go through the history of the waiver because I think everything was cruising along the same so long with the threat that it was going to happen, which is why I'm cautioning we're not doing that with day treatment, with waiver. We were just going along knowing that everything was going to change, but never really believing that it was going to change. So the history is that there were new federal regulations proposed in 2010. OMH knew of the regulations, the feds knew of the regulations. Todd Shank, my home and community-based waiver provider here at the Jewish Board at the time, fought with me, Robert Sisma too, co-chairs of my waiver committee, tooth and nail, that OMH should apply in 2011 for their 5-year reauthorization for our home and community-based waiver without one single change that applied to that proposed rule. It was only proposed. So we knew in 2011 that we were facing a challenge with the waiver program. I may not have done a good job of making that clear to our providers, and I am sorry about that. The final regulation was published in January 2014. It was effective March 2014. And the continuation of federal financial participation, federal match on our waiver program has only been alive 3 months at a time since January 2016. We have been on a ventilator, and people didn't know it. And again, that's my fault. Meredith wasn't having those monthly waiver webinars for her good reputation. She was trying to convey to us that we were in trouble. And I don't know that everyone knows that, so I'm just laying it out there. A breakthrough came about 2 months ago when CMS agreed that a temporary fix for our waiver problems would be to allow non-compliance with the final federal rule as it pertains to conflict-free or conflict of interest. They gave us a waiver for lack of choice because we had set up a program that had just one provider in many counties or two providers, and they allowed for those circumstances to continue only until the existing waiver array becomes spa services and we transition the ICC to health home into the health home serving children. So the fact that we are still going to get federal financial participation is a temporary fix until we transition. And you heard in our first presentation that that transition is still a question mark. So I am stating for the record, as much as you hate this transition for the waiver, it can only get worse because either we don't transition to the 1115 waiver amendment and health home serving children, and you have to break completely waiver services from ICC and comply with the federal rule to keep our 1915C waiver operational, or we move to health home serving children and that ICC rate goes down to what the health home rate is. So let's everyone just take a moment and digest all of that information and know that this horrible situation was not unpredictable.
And it could have been worse.
And it could have been much, much worse.
It always could be worse.
I mean, this really could have been worse.
So right now the status of the timeline, because I know this is the next most popular question, when will the transition to these unbundled rates and the firewalls go into effect? Our current 3-month extension expires June 15th. Meredith is confident we will not get another temporary extension. This is it. She did not close the negotiations in April, as she indicated in our quarterly meeting she thought would happen. Therefore, July 1 transition, not an option, because she has made it clear to CMS, because of unions, because of layoffs, because of staff restructuring, we need 90 days. Because we have to lay people off when we go to 1 to 9 and make these changes and reduce rates. I am now recommending to Meredith that she not negotiate anything less than an October 1 transition date. The negotiations are between DOH and CMS. That's just a recommendation. But we're not going to be doing this transition July 1st, as you may have heard. Okay. I put other stuff in here about the good news about the waiver changes, okay? So let's just pretend for a moment that we care, that there's good news before we get to the rate. We'll be able to immediately serve kids up to their 22nd birthday. So we'll have to develop a transition age youth approach and expertise on our staff for that population in the waiver program. We'll add the 3 new waiver services, which is supported employment, pre-vocational, and youth peer services. So now your waiver program will be able to add those services, and you have to be thinking about recruiting those type of waiver service providers if you can. You're going to have to submit your conflict-free administrative plans to OMH, and I think it's tremendous that OMH is willing to look at those for you, because CFS and DOH don't want anything to do with it. So it's a nice support that OMH is offering, and take advantage of it, right? you know, obviously the unbundled rates are the problem, and the new job descriptions and the staffing and employment changes are huge. The qualifications will be downgraded, so the fiscal risk, let me just go through this slide one by one because I put the qualifications here. The fiscal risk exists in this transition because CMS does not believe the proposed interim rate for ICC is justified. They're proposing, and I know you all know, $1,232.7 downstate, $1,173.33 upstate for the ICC rate, with a caseload change of 1 to 9. You have to compare that to what the health home serving children rate is for care coordination and what the health home serving rate caseload is, because that's what CMS is comparing here.
But the problem, the caseload is suggested or recommended for health homes, so it's hard to make a one-to-one comparison.
But you could only have more. So if you're getting $800 and you can serve 40 people,
That's true.
It's just, this is just the reality of if you want to compare apples to apples, as CMS is trying to do, and we're trying to say, no, these kids are different, and our time and motion study's not really bearing out that we were doing so much different with these kids, and that's a different problem we'll talk a little bit more about. The ICC will only be doing care coordination and not providing any waiver services for the 9 cases. The credentials will change. OMH informed us at the quarterly meeting that they are considering requirement changes, including the number of face-to-face, including adding telephone, but they are going to carefully vet to make sure that when we do the time and motion study, CMS is going to accept that change to count towards work that the ICCs are doing. Because we only shoot ourselves in the foot if we make the job easier for the ICCs and then we get the money clawed back. The money will be given back, the bottom bullet. CMS is requiring another time and motion study within 6 months of the start date. So if we start in October, 6 months from then, to look into the new rate. And they will require give back and reduce the rate further if the care coordination workload does not justify the rate. So the job descriptions for the waiver positions will need to be rewritten by you because your ICCs now may be very highly clinical people and they are going to be an administrative caseworker going forward. So I hope that the members that are listening that have waiver programs are spending time with their HR department looking at the business plan, the employment model, the salary adjustments, the waivers, and all the things that you need to focus on now as opposed to that rate is too low. The rate is too low. It only can go lower. So we have to do some homework.
Well, and what's an important kind of thing to think about, these are the rates, so if spa services ever actually come to fruition, you're looking at what they're thinking about, and so as you develop this model, you know, these are the rates that probably are going to be in the ballpark, and as we know from the B2H, those services are usually very problematic from a financial point of view.
So on April 20th, OMH did a waiver webinar. If people did not have the opportunity to look at it, I thought they did a fairly good job of trying to itemize the type of work that the ICC would be doing. I took their big bullet points, but in their waiver webinar, they did a slide of a description of everything under enrollment and engagement that they believe will count towards the time and motion study, everything under planning, everything under collateral contact, everything under service plan and team meeting review, everything under documentation. So I can send that out again to everyone, but if you run a waiver program and you missed that April 20th, it's a good one. Make sure you take a look at the PowerPoint. We want to try to quantify what we think a good like we'll do a template of what an ICC would do, spending their time on 9 cases to give people a little temporary assistance. But I'm doing that in conjunction with Meredith because, as I said, if she changes some of the requirements, then I would want to capture the most accurate information.
And one of the things that, if you look at the regulation, the ICC has to only do 90 minutes of face-to-face work. 6 15-minute sessions, that is the minimum. And I think CMS, when they started delving into the rate, of course they would do the IRH, and that's where they addressed this rate. So Meredith did a very good, I think did a great job to get that additional 400 plus dollars. If you think about it, 90 minutes and you're getting paid $1,232, $1,232 a month. Well, we have to make adjustments to that in order to keep that extra $432, and don't forget the 7 cents. We're going to have to really up the face-to-face contact in order, when they do the time and motion study, to keep that additional increase of a third.
So concurrent documentation, anyone, while you're sitting there with the family? I mean, it's a change of what the ICC did. Yeah. So I want to give like time for people to raise questions and concerns and guide the coalition in what our advocacy should be for you on your behalf. So let's talk waiver.
Well, a couple things. One is the other thing that Meredith mentioned was the possibility of increasing slots.
Right, that's a good point.
Once CMS gives approval, so that cases are divisible by 9, which in some cases are not now.
Jim, let me just repeat that so I can make sure that people heard. So one thing that OMH told us at our quarterly meeting is that they understand the challenge associated with a program that, say, has 12 waiver slots, because 12 is not divisible in a 1-to-9 caseload ratio. And so once they get final approval, they will be asking as a component that they can add some slots to the waiver program, so that 12 slot program would go to 18 to afford you 2 care coordinators, which should help with the volume around the IIH and the crisis response, again, assuming that families want those services.
And the other thing she mentioned is once they reach an agreement with CMS that they would provide some sort of technical assistance to providers to develop a workable transition plan. But I think what's needed, because everything is so vague, we don't know if it's going to be August 1st or October 1st, or,
right.
But it's going to be within the next 4 or 5 months. So I think one thing is I think a lot of us would like to transition earlier rather than, do it on October 1st. Because, as you said, there is a lot of, with the business model, with human resources and trying to budget for your next fiscal year. So I don't think we asked that as a quarterly, but I think a lot of people would like that. Anyway, I would like to transition early.
Like have a transition.
I'm sure that there could be individualized transition plans, but I'll ask that. So agency-specific transition plans.
And also the held harmless, because that's the concern as the expectation. If we're moving towards a household model of BA 2 years experience or MA with 1 year experience, the present waiver model is BA with 4 years and MA with 2 years. So if we're going to make that transition in staffing in that period, we got to be held harmless that if I hire someone when a vacancy opens up for 2 years, and I'm going to still be doing that during the transition, that I'm not going to get a call years down the road saying that service cannot be performed by that worker.
No, that's a great point. And I think that's on any of the change in regulations and the caseloads. If we are allowed to do that without risk of clawbacks on the old Medicaid model, I think that would be very helpful.
I just wanted to ask if internally we looked at whether there was any paperwork we would recommend eliminating, and we didn't really come up with any. So wondered if others, because really, even though it's a lot and it's overwhelming, it all serves its purpose.
Meredith did allude to that they might do something with the 30-day initial assessment.
Right.
So that, we'll wait to see what the recommendation is from OMH. That was the most common paperwork complaint from providers, and so there's something under consideration. But again, pending CMS approval of a change, she was reluctant to give us details.
Right.
But any other paperwork reductions that people can identify, you know, again, we've asked over and over, and no one's ever been able to really identify anything. Because, you know, there is a compliance and a Medicaid, documentation issue, and honestly, train your staff. Any questions on the line? Nicole, does anyone want to say anything? No. All right, I think we'll take 10 minutes for lunch so people at their desks can get up and get a drink of water. Open your lunch if you want. And we'll get back on. We'll get back on at 12:20 to finish the meeting, okay?
Okay, thank you.
Julia, is there a password for getting into?
Yeah, it's really complicated, but I'll tell you.
You have to go onto the Wi-Fi guest, and then they send you it. You have to register it.
Oh.
Send you a password.
Oh,
Yeah.
sorry.
We're coming all the way down.
Yeah, well, I want to get the
Train.
experience.
Yeah.
I can find out with these guys in the morning. The Child Health Plus kids with an ID that looked very similar to Medicaid, and so the referrer didn't realize the child wasn't Medicaid eligible, and the home and community-based waiver step-down kids who were deemed eligible to be in the waiver program and then lost their Medicaid eligibility after they were discharged for waiver. So we raised with OMH the need to start tracking this population and the percentage of population, because we put them on notice. This would be a budget advocacy issue for us next year to try to include a health home, a non-Medicaid health home benefit in the Child Health Plus package, so that Child Health Plus would have to reimburse the government rate. I know that this sounds a little far-fetched, but, you know, they like Child Health Plus, and we'll talk a little bit about reauthorizing it at the federal level next, but this would generate another non-Medicaid revenue for you within your health homes, we believe, because we think this is a fairly 15% population. We're thinking about 15% of the referrals would constitute these kids, and then advocating for more non-Medicaid health home funding in next year's budget. This would be a state funding option. David?
Meaning OMH money?
For CHIP, it would have to
for the non-Medicaid.
For the non-Medicaid kids, right now, OMH is the only one that's using their money for the non-Medicaid kids.
Because I would think it might be an opportune time in the sort of pre-move to managed care that the insurance companies actually step up and take care of their own responsibility to provide care management for these kids.
Well, that's why I'm combining it with CHIP now. If you think that we should go further than that.
Yeah, you know,
we can't get CHIP, we can't get
an opportunity to bring the Department of Financial Services together with OMH to discuss increasing the contractual requirements on the insurance and the health plans to provide, you know, the essential benefits, as it were, although those are bad words now.
But that was also part of the newer HCBS services, care management. So, you know, there was probably opportunities to get some of this covered there.
Right.
I mean, it was always the intent of the Office of Mental Health to not do a carve-out of the kids, specifically because if the plan had the kid for their health care and then started to see, you know, what benefits they could get by providing mental health services or other unique benefits, that they would add those other services to their commercial lines as well. I mean, this was a philosophical discussion at the Kids MRT. If we keep the Medicaid kids whole and the plans start to become familiar with what helps Medicaid kids get better, will they learn and be interested in helping commercial kids get better? I mean, it's a little far-fetched because...
Well, and pediatrics is included in the health home, you know, armamentarium, so they're getting a free ride.
Can I ask, for those that are providing adult care management, you have an issue of adults losing their Medicaid status and not knowing about it.
Yes, yep.
So just, is this a good idea, bad idea, the right service to try this on? Okay.
So it's the one service that clearly is in the health bucket as well as everything
Right.
else.
Right. All right. Some feedback on the VBP readiness funding and the reactions to the sessions. I mean, I really would like to take a few minutes to talk about this. I attended the Albany session, as did a couple of people in the room. I know that others attended the other sessions. It required me getting on a broomstick and running down the hall to scream at the CTAC staff, if you don't mention the word children in the next 5 minutes, I'm taking the 45 people I asked to come here today and asking them to walk out, because it was so adult focused, I just couldn't believe my ears. It wasn't even mentioned that there was such a thing as the Children's Clinical Advisory Group, not even mentioned. And so then they tried a little bit to make it more kid-centric until the end, when Bob Myers unequivocally said to my vice president, who was on the phone, who raised the issue about, you know, we were supposed to do this or we were going to go out of business. We were supposed to do that or we were going to go out of business. Now you're telling me we're supposed to do this or where there's no future. And, you know, and Bob Myers just said, listen, if you don't have 85% of your population enrolled in Medicaid managed care, this isn't for you.
And Gary Weisskopf basically agreed and said, I'm not sure why you'd even want to think about it.
But in stark contrast to those statements, the day before at the OMH quarterly meeting with our board of directors, we were urged, encouraged, cajoled into considering this funding as an opportunity to get ready for alternative payment methodology. And so I have done two things based on this experience. I have advocated to the people we met with in Albany before the value-based payment session that they need to do a set-aside within the $20 million to go to planning grants for children. That they have to do it just based on the fact that, you know, we're not going to wait again. We're not waiting until the next round of money. There is going to be no second round of VBP readiness funding. And the fact of the matter is that 2 million children in this state are already enrolled in Medicaid managed care. They are all the kids that are enrolled in Medicaid managed care for their health services. And if nothing else resonates in this entire discussion about what we should be doing differently for kids, integrated primary care and behavioral health care is the key to a future functioning for kids. And if all we do is planning grants to integrate primary care and behavioral health care for the kids already enrolled in Medicaid managed care. They may not be enrolled for behavioral health services, but that doesn't mean they don't need behavioral health services. And Andy Cleek clearly said that value-based payment can include fee-for-service reimbursement. It was part of the presentation. So the payment would go to the primary care physician, and the primary care physician would reimburse or pay for contracted behavioral health services for the kids that go to their practices. So I'm thinking that we need to do a sign-on letter that urges alternative payment focus for integrated care for children. Start with the members of the clinical advisory group and the members of the opportunity to test it. And Jim, I don't know if you want to talk a little bit about what our thoughts were in terms of groups we could reach out to, or.
Yeah, and so a couple of things related to this. I mean, 2 or 3 years ago, Greg Allen was very clear to us that if we want to access any of the new resources that's going to be made available, that you're going to have to get on the value-based payment train. And so everything we've been done is focused on it, and so really to pull the carpet out from under us is important. So Andrea, again, has done a nice job in creating some linkages. And one of the proposals that we are thinking about is really to partner with the New York State American Academy of Pediatrics and put together a value-based payment proposal. And they're very interested, and so I think this is something that would have value for the coalition and our members who are providing children's services, and we're looking for ways in which we might be able to integrate better with a range of pediatric practices.
And so the American Academy of Pediatrics in Districts 3 and 2, which are the down from Dutchess County down, have 10,000 pediatricians. They have a significant portion of Medicaid enrolled kids. They absolutely, Ellie Ward is on the Children's K. She knows that there are no metrics, that they haven't identified what it is. She thinks working with us to do planning grants to not only identify the metrics, but the means by which they would be collected, which is where my psyches question was going. You know, a platform to support, you know, a planning grant. And, you know, I don't know if it's the right answer. I think we have to push back on the fact that they said they want us to apply for grants by the RPC region. I mean, there's not even enough covered lives in the 11 RPC regions for that to make sense. I don't even know where that one came from. And I think they need to be told that it doesn't quite fit. But I did communicate with OMH that I thought they had to make a commitment. Of course, I asked for 25% of the money to go to kids, but that won't happen. You know, I think that we could negotiate a number, 3 planning grants to go to kids, you know, $10 million to go to kids over 3 years. I don't know. I mean, we'll have to see if we can get any traction around a carve-out, but I think there needs to be a commitment to children. And I think that it's ridiculous to think that integrated care, if we don't get anything else approved by CMS, we have not one new service, we never move to a new array of services, we should be integrating our practice with the pediatricians who see our kids for their health reasons.
And I think the positive of that, and going back to the discussion with the CHIP kids, is that if you're working in an integrated care model on a Medicaid, then the managed care company is going to have to do a parallel process for the non-Medicaid kids, because I think that has to be integrated on both ends. You know, if this works out and there's value-based payment, so then with the CHIP kids, there might be health home services or other services because you're already doing it in an integrated fashion. So I think that's going to be the positive consequence of this if we're able to do a pilot like this.
Well, and I think because truly integrating with pediatric practices is, again, very complicated. There are a lot of different ways you can do that, and it would be wonderful for the coalition to take a leadership position with the American Academy to create a variety of models and really allow and put out there what are the options both for us as providers and the practices themselves for, you know, to explore.
And the planning grant in the first year would be to identify the metrics and to identify possibly a reimbursement methodology. Then in the second year it would be how we would collect the data and what the models might be. But I just don't feel that we should be discouraged by the fact that no one was encouraging us. And those are value-based payment sessions.
In the New York City area, you know, we have Thrive New York City, right? And there's a lot of efforts around this now taking place. We do have a couple of pilots. I know in Staten Island we do, and there may be some replication.
Are they with hospital centers? Are they with, I mean, just pediatric practices? Or
yeah, no, these are actually with pediatric practices, and they're using the mental health consultants from the Thrive New York to go into the pediatric practices, and they're doing baseline studies, and they're following effectiveness. They've developed some screening tools and metrics. So there's some work going on now, and just strategically, I think it's good to hook into where there's already energy and some money and see if we can extrapolate on that. And we're also looking at that going into hospitals, but that hasn't been the focus. The focus is in the private pediatric practice.
Yeah.
Now, are Thrive New York people who are in pediatric practices working for or part of your organization or part of the Thrive New York group, because they're pretty much independent?
They are trained through Hunter College, that they are employees through Hunter. They're not ours. They're actually, it's not connected with my organization at all. This is going directly. We help broker some of it, but it's a direct relationship with Thrive New York and mental health consultants at the pediatric site, and they have the evaluation staff looking at the effectiveness of these models, and they're going to be following it for that 2 or 3 year period. On Staten Island, we've identified, I think, 6 pediatricians who are interested, and we've already implemented it in 2 sites. So we become part of that because if the kids are flagged, there's some services that can be provided directly at
the pediatrician's office, right?
They're using telepsychiatry to help the pediatrician determine whether they could manage it themselves at the pediatric office, and then who are the kids who should be referred to.
Right.
There's a kind of
and then when they get referred to you, a true integrated model would be that you're doing health assessments on the kids when they come in for their other services and sharing that data with the pediatrician so that when he sees changes in weight or something that he wants to call the kid in for health purposes, right? This is integrated health care. And I do not think that it is inappropriate for us to think that we can add value to a system which is just providing behavioral health support, even if it's through fee-for-service, to kids who are already enrolled in Medicaid managed care. I don't think that it's not synonymous with what a pilot for value or a planning grant for value-based payments should be paying for.
And after the whole health home debacle where we received no money in startup, we were waiting for the $190 million and spread 8 cents of it. For kid services, we have to take the initiative because we've been through this movie before.
No more waiting.
No.
So are we okay with supporting Andrea to continue this discussion and to move this forward?
I would just add that
linking in. Yes,
right.
I will. So, mentioning telepsychiatry, on May 4th, McTack's going to hold a webinar. Chris Tavella from OMH, who is the quality director, is going to staff it. They've outlined for me what's going to be discussed, so I want to promote this because I think that it's important for the future of all of our operations. Beginning in June, providers will be able to contract with national telepsychiatry companies to address some of their staffing shortages. Yes.
Okay, say that because, and I'm stopping this because we've done a lot of work in this area, and in fact, part of the issue was that we couldn't have psychiatrists working out of their home. They had to be.
That's going to change.
Wow.
And the license.
And
the license. You had to license a site.
It's going to change. So these are changes in regulations, guidelines, and practices.
Wow.
By September, you'll be able to contract with licensed mental health professionals back to the captive PC model that will allow providers to access psychologists and other licensed mental health professionals for therapy and crisis via telepsych. The psychologist will not be able to do assessments via telepsych, so that still is a bottleneck. But
Yeah, that makes sense.
So this is happening when?
in June for the national telepsych contract, and by September for licensed mental health practitioner telepsych. So they will go through the process to file the administrative action with OMH to be able to access this service and bill for it. And at my request, they will include a description of what RTS can do related to telepsych in terms of providing or receiving telepsych from an RTF location. So that will all be covered in this webinar, and I urge 100% attendance because if nothing else, we have a shortage of professionals, and guess what? If RTF can sell telepsych services, it might
Well,
be
I'm more interested in, I'm still
2 p.m. in McTack.
I'm still interested in whether they can use it to deal with the restraint.
They cannot,
Okay.
and that's going to be said on the webinar.
And I think our staff is going to be part of that
Ask
webinar
the question,
because,
yeah.
no, part of the,
Oh, okay.
because we've done telepsychiatry now in New York City. We have several satellites that have been approved and have been operational, and it's been going very, very well. In fact, we're working with the Hudson River Field Office to license a psychiatrist home as a satellite. And maybe that's
It's
not
going to be,
necessary.
I think it's going to be addressed. And going back to the idea of integrated care, this whole notion of being able to consult with pediatricians or consult, or with, for the pediatricians to be able to pay for the time. This is all related to what we might be able to do in an integrated care model. So I think it's very important stuff, and I really do encourage people to participate, and I'm glad that the coalition was able to influence a little bit about what you'll hear by throwing the RTF centers. So moving forward, we still have 8 weeks left to the state legislative session. Again, in the theory of collaboration, I'm doing a couple of innovative things. I've identified with Families Together in New York State, and our group will be buying a table at their conference this weekend where we'll be handing out materials to the effect about the reauthorization of Child Health Plus, or the Federal Child Health Insurance Program, CHIP, and the value of the program to kids in New York State. And we are going to be doing, as part of Children's Mental Health Awareness Week, meetings with state legislators to make them aware of the grave dangers associated with the debate around CHIP reauthorization at the federal level, how it could be used negatively, and that they really need to be communicating with Congress not to politicize this reauthorization and to keep it as focused on child and family needs as possible. And so we're working with Families Together to try to do some grassroots advocacy to the federal level about just decoupling CHIP reauthorization from any other healthcare reform discussion. It was passed bipartisan in its initial created as a bipartisan program. It should remain a bipartisan program, and it should be decoupled from anything else that happens related to healthcare reform. So look for more information and sign-on letters. Families Together has done a great job of getting those electronic letters where you can generate your signature and stuff, and so we'll be working with them around that on that issue.
Do we have any sense what the current climate is for that? Because I'm not optimistic that there's much interest in general in the Republican side of any of this stuff.
I think that there will be a lot of pressure on Republican congressional seats to reauthorize CHIP. I think that they continually underestimate how many people access their health insurance through these government-sponsored programs. I think that the risk is that this president will try to put provisions in that do other horrible things to health insurance and for coverage. And so that's the uphill battle.
Are we working with the National Council on this piece? Because I would think this has to be a national issue, because if it's just a New York State issue, it's not going to go.
The materials that I've been getting and the sign-on letters that I've been getting are from Families First USA. So there are other groups, but I can certainly reach out to Linda, to make sure that they start to reach out to us in a more significant way. Becca?
So I did get a question. Kimberly Kadziolka asked, has the invite for the May 4th webinar come out yet?
It's on the
It's on the MECTAC website, which is just MECTAC.com, I think, and then you'll see upcoming events, and you can register through a link there.
Yeah, there's a calendar. You can go to a calendar.
We'll resend it. We can send it out.
Yeah.
We'll send it out.
And we can publicize it more, too.
Yeah.
And Maria Cristalli, can you unmute Maria Cristalli, Nicole?
Yes, I can.
I have a question for Jim. Jim, I wanted to make sure correctly that you're working with your regional office to license a physician's home as a site for your mental health clinic. Did I hear that right?
That's correct. I mean, from what I hear, it may not be necessary under new regulations.
Well, Maria's trying to work on this. So what do you think, Maria? Are you getting pushback that it won't be possible?
I had a very good conversation, Andrea, thanks to you, with Chris. And then after that, and I didn't go as far as asking from a physician's or psychiatrist's home, but we did talk about very creative options, and he basically told me everything's on the table. Where we are currently with our outpatient clinic is we're developing a plan to transition some families to other providers and to also serve families using both telepsychiatry and mental health counseling. So our plan is to review a set of options with the regional office this Friday, and then go back with them to the table with Chris and the folks at State OMH.
Okay.
Yeah, we started in this direction when we lost a psychiatrist to a national firm who was basically able to work at home.
Yeah. Things happen.
We're just not surprised.
We just lost psychiatrist anyway. Yeah.
Never has to get out of bed.
They don't have to take their slippers off at least.
Another conversation. Look away in pajamas with a tie. Neck up, from the waist up.
And they write off their mortgage.
And they write off their mortgage, that's right.
So the other legislative priority is a bill that Senator Ort, our indicted mental health chair, and Aileen Gunther, the Assembly chair, have sponsored. It would require the Department of Financial Services to collect data about mental health parity violations. This comes out of the fact that the largest healthcare lawsuits that have been won by New York State in the last 3 years are related to behavioral health parity law violations. And so this is going to be our legislative priority because we think that there needs to be an accounting for the plans. You know it as well as I do. When you work with these plans, they deny claims for the most bizarre interpretations of the rules, and you know that is partially education, but you know sometimes education is slow and lawsuits are quick. So we will be working on that legislation. I already explained that there's going to have to be some advocacy around the RTF to get access to the healthcare facility information program, and I'll help to guide that for the agencies that have RTS. And then in conjunction with the other licensed professions, we are asking for there to be a roundtable about innovative approaches to accessing children's behavioral health care despite professional shortages. Let me be clear. This is shorthand for we're not waiting till next year to talk about permanent licensure exemption, permanent licensure exemption. We want to bring in people other than the social workers to have a roundtable discussion about how we use other licensed professionals, how they're valuable, how in our settings they're supervised, and really try to get at legislators from a different perspective rather than in that really charged environment that happens when we talk about that bill and talk about the shortage of access to services. And we want to focus it on children's services because we're hoping that that'll soften them up a little bit. So I'm working with the licensed marriage and family therapist lobbyists and the licensed mental health counselors lobbyists to try to plant this seed. And I think that one of the things that I've thought of is that in our settings, because those professionals get so much clinical training in our setting, right? Like they have to get 3,000 hours for their test, you know, and it seems to me that we want those people. They are trained in children's services. licensed clinical social workers go to school and then they take the test and then they come out and maybe work for us, maybe they don't, maybe they work somewhere else. They're licensed, they can do a lot of stuff, but they may not have child and family experience. Other professions really have to work for us for quite a long time before they can take their certification. So let's not lose that. I think that that is a professional path that's unique to children's services and the specialty of treating children that is something that we don't want to lose. And that's the argument that we would like to make to legislators in a really positive environment and not in a charged political, environment. So that's what we're planning for the rest of the legislative session. If people have other bills or other priorities that you want us to be aware of, please let us know, and we'd be happy to join in whatever efforts individual agencies are working on. Questions?
I do have a question here from Aaron Newman. He asks, currently in Mental Health Service Corporation in New York City, agencies using these staff, those services cannot be billed. Will this be reconsidered?
Can you unmute? Yeah, Nicole, see if she can be unmuted, because they can be billed if they're under the supervision of a psychiatrist or
Aaron,
Hi, no. Hi, this is Aaron Newman. This is regarding the Mental Health Service Corps staff that was discussed.
Oh, the
You can't bill
Thrive
for
New
those
York.
services.
Thrive New York.
Right.
Okay.
Thrive New York
Yeah, they
Mental Health
can't be
Service Corps.
You cannot bill for their services.
No, that's not something that's under consideration to be changed. I was talking specifically about the other licensed professionals that work in clinical setting.
Okay, thank you.
Yep. All right, if you don't have an RTF now, stay on the line. I just wanted to talk a little bit about the RTF pilot project and what we learned from OMH at the quarterly meeting. The $5 million project will require an affirmative rejection or affirmation that you want to participate. We expect that this will have to happen by June, but we're waiting for a letter from them that will outline response to what we suggested that the pilots look like with what they think the pilots should look like, so it'll give all the RTFs a better idea of what they're signing up for. About it being called $5 million. It's not just $5 million. It's recurring funding. They've swept some funding from savings over the RTF closures that have occurred, the bed downsizing that have occurred, other funding that they've captured. I'm thinking that's probably the reserve bed days. But anyway, this is money that will recur over the 3 years. So let's call it the $5 million to make everyone politically happy, but understand that what you're signing up for could be more than that. This funding will go to the RTFs and state aid grants, and it will supplement your operating funds when you take the beds offline, and the beds can be taken out of your census temporarily, and at the end of the pilot, if it's a complete failure, you could add them back in. We'll cross that bridge when we get there. Again, careful what you ask for.
So it's $5 million in addition to the state share of the...
No, this is just state money.
But because if I take 2 beds off of line, there's a state share of that.
Right.
That continues to exist. Is this going to supplement that?
Yeah.
Yes.
That's what he.
So it really is more than $5 million.
Yes.
And it is recurring.
And it is recurring for the 3 years.
Yep.
Once you sign up, you will get that money for 3 years.
The status of the bed offline is not
Suspended.
Suspended, so your census will go down. But they're not changing CMSs, they're not closing the beds with CMS, so the federal financial participation would be reserved, so to speak.
Are the rate for the reduced beds and the $5 million?
You'll get the rate, you'll get your, whatever beds you keep operating, you'll get your rate, and AMO explained that they'll have to look at the methodologies to make sure that they don't unduly harm you in any way. So for example, 14-bed RTF. They are going to allow 14 bed RTFs to participate in the pilot. If you wanted to take 2 beds offline, do you completely fall out all of the screens with only 12 beds, right? I mean, just because you're not meeting some kind of thing. They will look at the rate methodology to make sure that you're, you know, being held
I
harmless.
thought he said he still needed to answer that, whether the rate change.
So I'm assuming that the beds that are suspended are not included in the vacancy rate issue? They're removed.
Yes.
They're removed from the bed reserve day policy, yes.
So they don't count towards the vacancy?
No.
So then, these are pilot monies that don't result in a rate increase, because the rate increases are on the CFR and like a formulary?
Yep, these beds would not be reported on the CFR anymore.
Okay, so
They won't get,
this pilot doesn't increase your rate. It's just a supplemental.
Well, it may reduce, it may in fact change your rate, because if it's based on, let's say if you're going from 20 to 15, they'll rebase the rate and probably look at your costs for the 15. Huh?
They don't change the CFR formula.
two years from now, the rates could be affected, but that's what Emil's saying, that they will do an evaluation of how they can tweak the rate methodology to make sure that it won't happen.
Because they
Your
could,
overhead costs aren't going to change that
they
much.
could in fact create a budget-based rate for the 15 new configuration, right? They could do that.
Yeah, I don't know that he mentioned that.
We played around with
And Dave said it's a good thing.
to see if you reduced your beds and you plugged that in, you recalculated on the remaining beds, and you got a new enhanced rate. But some of the feedback was that you can't just increase the rate that way because of the CFR and then you're over screened. So they actually have to change the screens in order to change your rate.
And
So my concern is after the end of the 3 years, what happens when, you know, in terms of the pilot monies, you know, now you have a service, this is what the service costs, and then they say, oh, well, the rate, you know, we can't pay you that rate.
No, let me make sure that
I think
2 steps. In the short term, the initiative would be to identify opportunity where demand is going down, resource available revenue, and pay out supporting operating over a 3-year pilot period. The second step would be revisions to the rate methodology that would support the system going forward. And they have hired Dave Panicia, who used to work on the RTF rate methodologies, to be the consultant to help them with this project. So I really feel that there is a commitment, unlike the commitment from OMH, that the rate methodology will be revised within time, that you're not putting your future revenue greatly at risk. I'm not going to say 100%, but, you know, I do feel like there's a commitment here to revise the rate methodology as needed going forward.
Yep. No, and I agree. I think Emil is very much trying to work with us to allow the flexibility to pilot some new programs, and he understands the fiscal impact, and do I think he's thought it through what happens in after year 3? No, but he has said, okay, you can take them offline on a temporary basis in case you want to put them back in after 3 years.
And he developed the initial rate methodology, whatever it was, 25 years ago, or 30 years ago.
We're in good hands. We have a friend in Dave.
They said temporary, but they also said that they're hoping that managed care, other funding sources, state plan other services in 3 years will then take over the funding.
Yes.
Right.
So that was a bit of a concern. And the other thing they said is about risk. You know, they said, you know, they're talking about uncertainty of referrals, which we all know about, and that commercial insurance will definitely not want a 15-month length of stay. So they were really focusing on decreasing length of stay, and they said, if you don't do what you say you're going to do, there is a risk of taking money back.
Yes.
But I think they're saying the pilots, they're not focusing on length of stay. The pilots, they want to focus on residential crisis, short-term intensive services as an alternative. But within your RTF operation, you should continue to be focusing on how you change the program. But not necessarily paying people for length of stay reduction pilots, which is something I proposed, but I think they said length of stay pilots isn't really what they want. They want alternative service
When you want
pilots.
to test the
The length
community
of stay, the state actually has a savings because the more use that you're cycling through the
Yeah.
bed, the lower cost per use that benefits the state. But your cost, in terms of like the startup and the front loading, is actually going to be higher. So they're happy when you reduce length of stay because the more kids you can service, and if you look at, I mean, it's volume, it's a value-based payment model with how many kids you're using. But my other concern was like you were saying about you take these beds offline, they're suspended, you use these monies to effectively, whether it happens officially or not with the changing of the rate, the remaining beds are being paid at a higher rate. What happens when you put those beds back online? Are you going to an old rate? Are you going to a new rate? Are you, I mean, not so much.
I don't think they know
It's going to be a
that.
new rate methodology.
And honestly, there could be a new budget-based rate in 3 years.
What the hospitals are doing is they're reducing their capacity and charging a higher rate.
Right.
You're like, why would you almost like, why would you want to go back to more beds if your revenue isn't gonna, you're not gonna increase your revenue to support that? That, I don't might want to sign up for that.
As an infomercial, thank you to all the RTFs who have been providing me your census information. I launched today to our colleague organizations, Teenies, Families Together, all of the groups. I haven't got it out to you guys yet, so thank you, but that RTF bed availability live count about beds, there are 48 RTF beds available this week in the state.
It was 75 less, I think, in CARES from last March to this March.
Yep. So you're not alone. 10% of the beds are not in. Now we'll see if this effort to publicize that to people, and I put it in the concept of, this is the greatest urban myth that's ever lived, is that, that RTFs are full, and that I'm telling people it's, it's fake news. And,
I would use that one.
we got tremendous response from the advocacy organizations, Gail Nayowith and Jennifer March-Jolie of Citizens Committee, congratulating us on putting this information out there. So let's take this from both sides. Let's participate in the pilot. Let's test our crystal ball about what other services might be good for your agency and for kids that you serve. But let's see if we get more referrals, because people can go online and see where beds are available, right? So
we've been so discouraged about making referrals to our
I know
together. I think it would be helpful to get the word out to the clinics.
Oh, yeah?
Oh, yeah, no, I'm going to put it out to our listserv. I just
And how to go about to advocate for the beds.
Trump is going to tweet about it.
I will all follow.
There you go.
We're going to make.
I said all serious
Okay.
about asking for a
Let's-
pilot that takes outside referrals without PAC, and then some type of a UR certification.
That one's on the table, so one of the things I put on the table is take beds offline and sell them as commercial beds and not have to go through the PAC. And we don't know, we didn't get a response yet, but that could be a pilot.
Well, go ahead. I think what the length of stay
That's
issue,
the problem.
the issue with length of stay, the length of stay issue is for the pilot beds, that they're not interested in funding a pilot that doesn't change the length of stay with the kids in the pilot. And he did say that's where you'd be at risk. If you propose something, you take them off beds, you're going to sell them to somebody else, but the length of stay of those kids is no different than the kids in the
Like
original.
the short length of stay everywhere is part of what is preventing kids from getting to the RTF, because kids in the hospitals are not going to do a packet. They're not doing a 75-page packet.
Right.
They're not going to.
Well, they might if they think there's actually a bed out
I
there.
don't think they are. They're sending them home and they're getting lost and they're
Well,
they're homeless,
okay.
they're AWOL, they're.
PAC is a problem. I think we've said it every time we've had an OMH meeting. PAC is a problem, and the restraints are a problem. So they're not open to changing PAC, and I think the belief in OMH is that the RTF basically is a broken regulatory system, and that it's its model is time has come, and so I don't know as if there's a lot of interest in saving an RTF as is. I think.
But if we put it in the parity report that kids that get referred and then they don't get access to the service, then maybe there would be some legal interest. And that's part, believe me,
I
it's
think
all.
it's also our marketing too. I mean, where the RTFs are still looked at as the intervention of the last resort.
Right.
Why are
That's
we
right.
doing that?
Fail
They
up.
really
Fail
about
right. Yep.
prevention. If we get these kids earlier, you are going to have a shorter length of stay. You are going to be successful in doing your background checks. You wait until, they're 17 and they've been denied access for 6 years. You got a large problem.
Is there any way that we could study that? No, there's this short response we need to act now. But, we're making the claim that
Marlene Radigan did it at OMH. It's been done. So she presented at a national conference that this is, in fact, the truth.
Oh, well,
yeah.
Okay, right. Then I'm not.
No one listens to us.
Okay, so when is?
We got to get the word out more about
I know.
Okay, we need to move on.
I know.
When is the next going to be the RTF provider group call?
I have to reach out to the chair to get the date, but I'm thinking, we'll have a May RTF provider group call to make sure that people understand what the next steps will be.
And they said they were going to send out their guidelines for us to react to before.
Yeah, they said in May, and that's why we'll have a call to
right
share that, and then we'll have to, I think the RTFs will have to be prepared sometime in June to make a decision about participating.
Talking about value-based payments and value propositions, what you were saying is that having these RTFs and so, and having this available has a short-term and a long-term impact on cost and stability in the community. I don't know how that paper was written that you're talking about, but I think it has to be put in those kinds of terms.
Okay. We probably need to move on because we're over time right now.
I know. So the last thing, I just did a slide on the Health Home for Children cut that was included in the budget. The other bad news last. The enacted budget cut includes children's outreach, which I find disturbing because we've only had 2.5 months of live experience with children's health homes. So how do we know that there was a problem with outreach status? But the cut was to reduce the outreach monthly rate from $135 to $100, to limit the outreach to 2 months, and the second month of outreach must include a face-to-face visit. The savings will be reinvested, but when I asked the Department of Health whether they would be reinvesting the kids' savings into the kids' health home serving children, I only got anger as the pushback, not an answer. So I think that there's value in us identifying, being outraged that we're being cut because of the experience on the adult side. I don't know that we can undo it. It's a budget cut. So there's some savings assumed in this state fiscal year beginning in October, but they have to get CMS approval. So, but anyway, beginning in October, this cut would take place. I definitely think we need to organize ourselves around reinvesting whatever's saved on the kids' side into the kids' health home serving children. I throw out as one of the things that we've talked about getting reimbursed for complex trauma assessments.
Yeah.
We could reinvest the savings into complex trauma assessments. Just a proposal.
That's a great idea. I don't think there's going to be any savings because I think people will just skip outreach in a row.
Well, and I think part of
that's not so easy. Can I just say, Lana's saying we don't need the outreach period because unlike adults, we know where the kids are.
Right.
And that's not true because of how long it takes to get consent and to get
Well, and that's, I think,
eligibility.
that's why the surprise on all of us, right? I think we all believe it would be an easy transition, and the fact that we've had so many kids in outreach and engagement has been a surprise to us.
It's exactly. We've been going out and working with them, trying to get the eligibility criteria before we enroll them to make sure that it's SCD or complex trauma.
That's during the outreach period.
Yeah.
That's why we need the outreach period.
Yeah, and so the 2 months happens very quickly, and so it's not being abused. It's necessary in terms of the kids.
It's the myth that there's a bunch of clinicians hanging out there ready to do these assessments.
So
That's that. And I guess I was speaking more for kids in foster care where there are clinicians who can do these things.
Not always.
So we will work with other groups to really promote this. I know there is a health home coalition. My concern is always that it's adult focused. So I'm going to encourage those of us who are working with kids, you know, in CBC to advocate within CBC to make this an issue. There are 2 children's only health homes that this is an easy one for.
I'm just going to add that the Health Home Coalition and the New York State Care Management Coalition, NYAPers, Mahaney's, the Coalition for Behavioral Health, Kevin Muir, who's iHealth, and Lori Cole's group are coordinating, and they are identifying some of the concerns regarding the children.
No. Jackie heard me yesterday describe what she needed to bring to those meetings for the concerns for children, and so now she may bring them to the meetings.
I just want to remind everyone that at the Health Home Coalition, Danica Mills is an officer of that coalition, and Ray Shimmer, who's doing Shiny, is very active in that coalition. And and that Ray and that coalition did speak to DOH. So and Jody, and so they're all board members. So I think there needs to, definitely be coordination. I've said that a few times. There needs to be coordination, but whether or not they'll agree to do different reinvestments, I don't see that. I mean, I just have, and I just got a PowerPoint from Jason. He just sent me a PowerPoint, Helgerson, and it's interesting because he focuses more on the kids things with the SPOA, and he says, that's where his mind is right now as far as health homes and outreach. He says monthly meetings with SPOA to help establish good communication between SPOAs and health homes and facilitate SPOA referrals made to health homes through the MAP. The care management agency required to inform SPOA of the outcome of their referrals.
That's adult.
That's got to be children. It's health home service children. But I'm just telling you that.
That's the meeting that's happening now. So right now there's a health home implementation webinar that we should all be on.
We should be on. Right.
So
he's speaking for me.
So the other proposal for reinvestment that David knows of, David?
Well, yeah, it's poorly defined as yet, but there are discussions on the give back side of this that for the continued enrollment of individuals defined as high risk would have higher monthly rates for health home continued stay. So as a way of making sure that high risk individuals remain engaged in the health home, you'd get incentivized payments now. What that means and how much, I haven't heard any of that, but I've heard no discussions about how that plays out on the kids' side of things either. So.
Well, I think there may be starting to address. There's a 1 o'clock webinar, and I'm just seeing he's at a conference on Friday, and these are his. He's gonna, that's they're addressing. But we do have. I just want to say the Health Home Coalition. I don't want to, Danica is a player in CBC, as is, Jody, and as is Ray. So they're very active. I don't want to make like they're not active.
They're active. They need additional support as well.
Yeah, and I think the other thing, and I say this to Andrea, which is confusing on the kids side, is all the board members of those health homes are TCM agencies. So a good portion of them. So how, when you're going to advocate, is there a difference? Because we heard on the outreach piece that they didn't make that big of a deal about the outreach piece, when they had those meetings. The cut was the cut, and that people thought outreach was the best place to actually have the cut. And I think, if I recall right, Mr. Shimmer said on a call, the other day too, if you had to take the cut, that would be the best place to take it. So I do think there's some confusion on the kids' side because of because how can you be, I still struggle with this, how do you have a health home and 50 or 70% of your board members are TCM agencies?
I have sorry, go ahead.
Yep. Go ahead, Nicole.
I have a couple questions on the line. From Kimberly, she asked, at the end of the webinar, can I ask this general question? Is anyone using this is the end, but is anyone using telemedicine for physician restraint monitoring? But Jill, just go back to that at the end, and I'll unmute her.
No, I'll answer it. No, and they will not be authorized under this change in guidelines. We asked for that, but the answer is no and no. No, it is not, and no, it will not be.
And we'll continue to keep bringing it up because we've been doing that for about 8 or 9 years. So why stop now?
Okay, go ahead, Nicole, the other question, because people are getting up to go. That's okay. People want to get on the train. Go ahead. Nicole? Anything else? All right, the next meetings. Confirm.
Not for discussion next, we don't have time, but you know, the whole single payer system in New York, and it's getting close to legislative vote and all of that. I know I'm involved in some efforts locally in my community to support it and other things. And so I keep wondering how it's going to impact all the changes, and I'd love to have some sort of discussion about it.
Okay.
They're only 1 or 2 votes away from that in the Senate. Not that they're going to get it. But
Not this year, unless the indictment comes down quick enough.
Anything else?
Anything else? The next meetings are up, but we'll send notices, and I hope for the New York City committee people that you enjoy doing this from your desk instead of going to 123 William Street. We'll hear from you next month. All right, thank you.
Thank you. 30, right?
No, 1.
I'm not on board. You know, we're not at
They already are.
Yeah, I'm not sure if it's a cat. He was talking very much about it.
That doesn't mean all minors are going to give up anyone the money.
Well, that's why.
Right.